I want to talk a little bit about the collaboration for those who did not attend the introduction session yesterday. So this collaboration between the University of Jordan and a couple of elite universities in the States, like Harvard and UPenn, University of Pennsylvania, and John Hopkins, are like facilitated through the Global Health Catalyst, which is aiming to like decrease the gap in knowledge and in healthcare globally. And we are building this collaboration on 4 pillars. One of them, and the main pillar, is the research, where we try to help in like training, as well as having some collaborations in research. For example, we are working with the Lancet on a series of papers that would be published about like the cancer in general, like in Jordan. And we are aiming to build on that. This collaboration is aimed to be over like 5 years. So I'm trying to trigger like for more participants. So if you are interested to be part and to help us, please reach out to the Jordanian Catalyst, like Dr. Laila, Tutunji, Dr. Qais Balbisi, and Dr. Yaser, Rayyan, and we'll be more than happy to expand on our team. The second pillar is on clinical care, and that would be through like consultation and through training. So research, clinical care, and training. Hopefully we'll have like some of the trainees, different levels to come and have some like observership practice here in these elite universities. And fourth would be about centers of excellence and quality improvement. And these, like, we will be hoping to start building some centers of excellence in the University of Jordan. Regarding this workshop, we try to choose the subjects and tailor it to the needs and what we feel that would be super important to start with. And it's like super condensed and super rich. And the speakers, they are super elite, and it's an honor to have them to be with us over this like workshop. I want to like ask everyone here, please, this is a safe environment. We told our speakers that we have super smart participants. So please ask questions, their expectation that they will receive some questions. So there's nothing as a stupid question, or shall I just ask the questions and they will be more than happy to help you with this thing. The other thing, this is a good opportunity to get to know each other and to build, like, we would love to see after this workshop, the establishment of some interest group. So if you think there's some people who are participating and have like share some interest with you, please reach out to each other and try to work together. The power is on the group. Again, I wanted to encourage you to participate in this survey, pre-survey, and there will be a second survey that we will send at the last session tomorrow, and then via email. And during that, we will ask you to give us some suggestions for future workshops, or if you have like any ideas about research collaborations that we can like work together on that. I don't want to waste more time of our like valuable speakers and attendees, and I will hand it off to Dr. Laila Tutunji. شكرا لكم جميعا، وبتمنى انه يعني تكون workshop مفيد، وان شاء الله انه وقت يكون مستثمر بشكل جيد. دكتورة ليلى.
Hello, hello everyone, and good morning, a very good morning to our esteemed guests from the US, and a very good afternoon to all of our esteemed participants from Jordan. It is a pleasure to be with you today. We are very excited to launch the second day of the Global Health Catalyst and the University of Jordan workshop. That is currently an introduction to clinical research, and like my colleague Dr. Salame stated, inshallah, there will be in the future more research workshops to be shared with everyone. And our aim, like Dr. Salame said, is to decrease disparities of healthcare and healthcare delivery around the globe. And one aspect of that is through knowledge and research and unification of research approaches. So welcome everyone, and I'd like to welcome our amazing and esteemed first speaker today, Professor Mary Diener West, who is the Helen, Abby, and Margaret Merrill Professorship Chair and the chair of the Master of Public Health program at the Johns Hopkins University. She is also professor of biostatistics, clinical design, conduct, and analysis of multi-center clinical trials. So it's an honor and a pleasure to have you, Dr. Marie. And we are very, very excited to start.
Well, thank you so very much for that introduction. And I am thrilled to see that there are so many interested people here, especially at the end of a busy day for most of you. So I'm going to share my screen right now. I also thought it might be helpful for me to also, let's see if I'm able to do this. Well, I was going to share my slides as a file in the box, but I might send it off later so that you'd all have a copy of these slides, and of course there will be the recording. And I will send, yes, so I can send it to you and then upload so that everybody will have this. But again, I thank the organizers for inviting me, and I thank all of you for attending. This is really exciting to have a 3-day workshop, intensive workshop, and to have so many of you here. The 3-day agenda is very ambitious, to start with principles of clinical research and to then go into quantitative and qualitative, and then even some basic statistics. So what I will try to do today is talk about fundamentals of quantitative methods in research, and try to bridge between the lecture that you heard yesterday as well as lectures that you will hear tomorrow with basic biostatistics. So please do ask questions as I go along, and I'll just start with the first slide. If this had been a much smaller group, I would have gone through and asked for introductions. Seeing that we already have 224 participants, I'm going to assume that all of you are working in clinical medicine or in the health profession in some way. And you've already heard a little bit about my background. So in terms of my professional career, I've spent most of my time working in multi-center clinical trials, but also some observational studies. So my goal for today is to talk about steps in conducting clinical research, fundamentals of good quantitative research study designs, and then a little bit on statistical considerations using an example. So if we think about the steps in clinical research, it starts with asking a question or stating a hypothesis of interest. So all studies really have to start with a hypothesis. And then the goal is to design an appropriate study to answer the question. And so the reason we're doing a study is because we don't know the truth in the entire population. So we're conducting a study on hopefully a representative subset of that population. The third step is to actually conduct the study in an appropriate way, collect the data from a study, which we do use as evidence, analyze the data, and then report, disseminate, and implement the results. So we'll try to touch upon each of these steps today. But the term evidence-based medicine is used a lot. And so just inserting this definition of evidence-based medicine, it's really the integration of of the best research evidence, and so that evidence comes from the data from an appropriate conduct and study, along with clinical expertise and patient values. So any research endeavor that we undertake should really be evidence-based and incorporate not just the research itself, but also the clinical and patient aspects. So how do we obtain quantitative evidence? It depends on the type of study design, the characteristics of study patients or participants, having standardized procedures for the intervention, often a treatment and follow-up, having appropriate comparison groups, and then paying attention to the participants' compliance with intervention, whether there are side effects, in addition to looking at the outcome of interest, the long-term safety, and having appropriate statistical analysis. So, so maybe I should ask how many of you have seen, and you can just raise your electronic hands, just to give me an idea, this PICO formula, this acronym PICO, which is used to help formulate a question. So seeing some hands go up, okay, great, great. So to review this then, P starts with defining the patient population or problem. So what are the characteristics of the patient that we're interested in intervening on? What is the health status? I is for the intervention or the exposure, depending on what type of study design. And so that might be medical, surgical, or preventative. Comparison is C. So being able to compare those that have a particular intervention with either a placebo or a standard treatment. Often we might be also looking at an existing treatment as a gold standard versus a new treatment. And then O is the outcome. So what is the clinical outcome that we are interested in investigating? So I'll just give you a few. Oh, and Ola, go ahead. So Ola might have still had a hand up from the question that I had, but if you do have any questions, feel free to raise your hand and to ask. Okay, I'll assume there's not a question unless I see another hand go up. But what I thought I would do is give some examples. I've worked a lot in the field of ophthalmology as well as oncology, and some examples of ophthalmology research questions might be, does sunlight exposure, is this associated with cataract development? Does high-dose vitamin supplementation delay the progression of age-related macular degeneration and vision loss? What's the best treatment in a comparison of treatments for a very, very rare disease, ocular melanoma, with respect to survival? Or a question like, does hand washing reduce the risk of a trachoma? So we're going to come back and look at an example of a study I've worked in with ocular melanoma very soon. So some of you may have also seen this pyramid of the strength of evidence across different types of study designs. And the gold standard is really a randomized controlled clinical trial. And you can see here at number 8, having a confirmed randomized controlled clinical trial, meaning not just a single one, but one that's then confirmed with a repeated experiment. But it goes from the lowest form of evidence, an anecdotal case report, through to looking at case series, looking at computer databases, or case control studies, or comparisons with historical control groups. So all of these are appropriate study designs. All of them you may be involved in, but I'll be focusing a lot on the attributes of a randomized controlled clinical trial and the comparisons that we can make. But all of these are ones that when I refer to certain attributes, all of these study designs, even non-randomized ones, need to have high attention paid to quality and different types of quantitative aspects. So what are the determinants of a study research design? And so first of all, it does depend on the question of interest. It also is influenced by ethical considerations. So there's a term called clinical equipoise. And so especially when we're talking about randomized comparisons, those should only be done if there is not clinical equipoise. In other words, if there's uncertainty with respect to what type of intervention should be used in a particular setting. The patient population needs to be considered and defined, and it's all then balanced by what resources are available, and those are in terms of money, time, patient population, as well as the logistics of carrying out a particular research design. So why is it so important to actually have a carefully designed research proposal as well as quantitative considerations? So there have been a number of previous types of studies that have later, after being used, have been found to be ineffective or detrimental. And some of these are listed here. One of them in particular in the US was the use a number of years ago of the drug thalidomide in pregnant women, which ended up causing birth deformities unbeknownst to the original investigation. So looking at the randomized controlled clinical trial as a gold standard, the treatment groups are established through randomization. There's a planned experiment to assess the efficacy of at least two types of treatments that we'll see in terms of the design. But then patients are enrolled, treated, and followed over the same period. So this would be considered the conduct of the study. When the outcomes are compared at the end of the study between the randomized group, this would be the analysis. So in a randomized controlled trial, we really start with the steps of randomization and carry this through the important aspects of design, conduct, and analysis. So what is randomization? So one definition of randomization is that it's a method by which study participants are assigned to a treatment group based on chance alone. So why don't I just ask if you could type into the chat, what are methods by which randomization can occur in a research study? Anyone? What are particular methods that might be used? Right, so Laila says computer randomization with software, computer programs. That's right. And so the computer programs, though, are ones that have a randomization that allow one to generate a treatment 1 versus treatment B, just as in the chat, as Zudi says, it's like a coin flip, right? So there's a random process in which treatment A or treatment B is assigned. And that is one in which there's no interference with the randomization. So it could be that with a coin flip or with a computer software program, you're doing this on an individual basis. So patient A versus patient B. Omar indicates selecting a random area. So it might be a population-based study in which we're not having a computer program determine this for a patient who's being enrolled in a study in a clinic, but rather but rather it could be a random area in which there's actually an entire village or district in which all individuals receive the same type of intervention. And so all of you are taking a certain order to pick up the patients, right? So you're actually assigning the intervention based on this randomized computer code, which in the old days, when it could be computer generated, but in a listing in which the randomized intervention code was put into an envelope. Now, the problem with putting it into an envelope and having an envelope picked is that can result in some bias. So it could be that that instead of having the actual random assignment done, it might be that there's some trickery that can be done by looking through an envelope trying to identify whether it's treatment A or treatment B. And then there are more sophisticated types of random assignments, as Rayyan is saying, with block randomization. So that might be that you actually have a group of 10 or more individuals in which there's randomization within those 10. And the benefit of block randomization is that you're able to result in often a more equitable randomization between, say, treatment A and treatment B, because you're randomizing smaller groups within a block. And dividing a population into strata can be another method for randomization. And so that would be in terms of stratified random sampling. So all of these, simple random sampling, stratified random sampling, it could also be systematic random sampling, in which if you didn't have a computer, you might be able to take every 5th, every 7th, for example, the same number and randomize in that fashion. Okay, but usually in randomized clinical trials, we're now using computer software, and this methodology then allows us to determine the treatment group based on a mechanism that's not determined by any other factors than chance. So what's the importance of randomization? The importance, first of all, is that it avoids bias in the treatment assignment. So this means that there's not a bias on the part of the clinician or of the coordinator of a study, for example, in giving a particular treatment or assigning a treatment to a patient because of characteristics that they observe the patient has. It avoids bias in the patient themselves picking a treatment or selecting a treatment. It avoids bias in terms of the family members of a patient and their preference for treatment. So this avoidance of bias is the main advantage of randomization, but it has a wonderful side benefit, and that benefit is that the characteristics of the individuals, meaning their predictive or prognostic factors, are balanced across the treatment groups. And so this is a side product of randomization, which allows us to say that 2 treatment groups of patients are as similar as possible with respect to both measured factors as well as unmeasured factors. Another benefit is that it allows us to control for time trends. So if it's a very long-term study where there might be some differences in patient characteristics over time, we would see that a comparison of treatments would be similar within each time interval. And because it's a random assignment, and most of our statistical tests depend on assuming an underlying simple random sample, it helps to guarantee the validity of the statistical tests that we're using in analyses. And because of this, the results of the studies of the randomized trial are more likely to be convincing to those who are reading the literature and making changes in practice. So there are considerations in the design of a trial, ethical considerations, as I mentioned before, but also having scientifically sound study design and methods with standard protocols and procedures. And so these are allowing us to enroll patients in the same way, treat patients in the same way, and follow them for the outcome in the same way. In conducting a study, so before conducting a study, it's important that there is ethical review by an institutional review board. And so this is a way of assuring safety is of consideration, that ethical procedures are being followed and standard procedures are established. But then there are other concerns, and those are of patient education. So in order for a patient to be enrolled into a clinical trial, it's important that the patient understands the process by which they will be treated, the understanding that there is no one best treatment yet known in the clinical arena, and that the patient fully understands this and gives informed consent. In terms of patient confidentiality, the informed consent would indicate that the patient's data are going to be bundled and analyzed together with other patients treated by that same treatment and made in a grouped comparison with others, so that there's no individual data that is presented in a report, and that patient safety is of concern, and that the safety of patients are monitored in some way, both internally in a clinic, as well as possibly through a data and safety monitoring committee at periodic times throughout the study. In terms of analysis considerations, the quality of the data is important. So quality, so let me just ask in the chat, what determines the quality of the data? What do you have to think about with high quality data? So Hala says whether there's bias in terms of measurement, so accurate data collection. Quality of the data can be linked to the sample size, and we'll talk about sample size. Absolutely, accuracy and reliability, valid. So all of these, and reliable. And that you're using the correct analysis measures. That's right. So, making sure that that you have valid information, that it fits the purpose, and that there's no missing important information. So I think I could take that from 2 points of view. No appropriate missing data would be not having a variable that's missing from the data collection. That's an important variable. And in terms of missing data itself, suppose that you have a variable that you are interested in collecting and assessing with the outcome, but if that variable has a large proportion of missing values, and that could be a laboratory measure, it could be a self-report, it could be a variable that's very difficult to measure. So having missing data will influence the analysis and result potentially in spurious conclusions or misguided conclusions. And certainly having standard operating procedures for collecting the data, making sure that there's quality control measures, also will decrease the amount of missing data. So having high quality data, the right data for answering a particular question, and decreasing the amount of missingness by whatever procedure can be taken is appropriate. And then in terms of analysis, using the correct statistical methods for the type of question that's being asked and the associated hypothesis is critical. And then lastly, having the appropriate interpretation based on the statistical methods is also critical. We'll look at each of these with an example. So back to the representativeness of the study participants. And so, you know, we are not able to collect information on an entire population. And so that's why clinical research studies are investigating subsamples, subsets of a population that we would call a sample. And our goal is to have a random sample in order to be able to make an appropriate conclusion about what could happen in a population based on the group that we're looking at in our study. So the aim of clinical research is to make an inference. So it's a conjecture, it's a conclusion. It's not necessarily the truth, but it's an inference about the truth of the effectiveness of an intervention in a population based on the results observed in a sample. So let me just ask, in terms of any questions regarding the sampling that we need to do when we're conducting a study. So, you know, there could be extreme biases involved if we selected in a non-random way. So if you handpicked a particular group of individuals and performed a study, you may be looking at a very biased comparison that results in inconclusive or misleading results. So what are some of your thoughts on the best way to identify a study sample based on a population in a clinical research setting? Is it the entire, is it a sample of the entire population that you're interested in? Or, okay, so you're bringing up points that we've talked about with randomization, educational brochures in terms of making sure that we do not, that we decrease the number of individuals who will actually be refusing the study. But then, as Laila said, so let's start with this, the people that are affected by the disease in question. So we're going to be limiting in some way the eligibility criteria for individuals in a study. And so it might be that, first of all, they all have a particular disease. What other features in addition to the disease would you consider in terms of eligibility criteria? So age, race, right, that you're inviting participants that fit the inclusion criteria, which is the opposite of the exclusion criteria, in making sure that they have the ability to give informed consent, that they have the mental ability to do so. So you might exclude based on having an individual who's not capable of giving consent. You might exclude based on age. So the disease itself might only occur in certain age groups. So you may not include younger individuals or older individuals. And then Bushra says not having confounding factors that may affect results. So in fact, there often are confounding factors. So Bushra, maybe give me an example, because the largest confounder that we usually need to control for is age. And so we often are not able to necessarily get rid of the confounding factors, but at least we can, unless you're meaning like a confounding factor. I'd love to know what example you might have, Bushra, in terms of a confounding factor that might affect results. But as you're thinking of that, I think all of you have given some great answers regarding having inclusion criteria, but those inclusion criteria then allow you to talk about a sample that's representative of a population with those criteria, but not beyond that. So, so limiting it to a particular subset is important. Okay, so before we look at the example, so physical activity level and life routines. Okay, so I think, and maybe people with rare metabolic genetic defects. So I do think that the last example about people with rare metabolic genetic defects, those could be a confounding factor that would influence the results, and it may not be typical with respect to the population that you're interested in assessing. So I agree that that would probably then be an exclusion criteria, that if you know that there are particular metabolic genetic defects in that disease that are rare and would influence the results, that could be an exclusion criteria. And then smoking or drinking are confounding factors, but I would say that that you aren't going to necessarily exclude individuals who smoke or drink, but you could collect data on them so that you would be able to try to tease apart whether there is an effect of smoking or drinking. Now, remember, in a randomized trial, our goal is that the two groups are balanced, but that we still wish to collect information on variables so that we can assess whether or not the groups appear to be balanced just in terms of distribution on, say, smoking or drinking factors in comparison to each other. Okay, we're going to look at an example to discuss this as well. But first, let me bring in the we'll bring in the statistics in a brief way. But I have to see in the chat, though, we do have pancreatic cancer and coffee, where smoking was a confounding factor, was actually missed in the particular study. And so I was actually involved as a graduate student in a pancreatic cancer and coffee study that took place after that famous study. So, so thanks for bringing that up. But let's talk about then statistics. I know you're going to get more on statistics in tomorrow's lecture, but we can really separate statistics into two types. We can talk about descriptive statistics. We can talk about inferential statistics. And so in terms of descriptive statistics, we're usually talking about summary measures. And those summary measures are measures of what we would call central tendency. And the most typical measures of central tendency are the mean or the average, the median, which is the 50th percentile, or the mode. So the mode is the most frequent value. There may be multiple modes as well. And then we have measures of variability or spread or dispersion. And so and all of the variables that you see here are measures, these measures of the range, which takes the maximum minus the minimum, the interquartile range. So maybe type in the chat if you could define the interquartile range. Anyone? Okay, so Amr, very good. It's Q3 minus Q1, so that means the middle 50%. It's the range of the middle 50%. So it takes the third quartile, which is the 75th percentile, minus the first quartile, which is the 25th percentile. So between the 25th and the 75th, you get the middle 50%. And as Laila said, it's the range between the 25th to 75th percentiles. The variance is as a squared measure. It's looking at the sum of the differences between each variable and its mean, divided by the sample size -1. So it's in terms of squared units. If we're talking about age, it would be years squared, whereas the standard deviation is the square root of that. And so we would take the square root of years squared to get a standard deviation, which is with respect to years itself. Yes, and so in terms of excluding outliers, I think those of you who answered the question about interquartile range are thinking about a box and whiskers plot, in which we would see the box as the shows the range between the 25th to the 75th. There's also then a technique for identifying outliers with a box plot, which allows us to see the upper outliers and the lower outliers. So yes, so for all of you who are talking about Q3 minus Q1, we're really talking about box and whiskers plots. And those are a way of showing the data. So we often then show the data in terms of descriptive statistics in tables, in plots like box and whisker plots, or in graphs such as scatter plots, Kaplan-Meier curves, etc. So that's just mentioning descriptive statistics. But if we thought about inferential statistics, this is where estimation and confidence intervals comes into play, and we'll define a confidence interval soon. Here's where hypothesis testing comes into play. So with hypothesis testing, we have to have a null hypothesis and an alternative hypothesis. So here I've given the null hypothesis is that overall survival is the same by treatment group, versus an alternative hypothesis that survival is different by treatment group. And so with hypothesis testing, we use the data as evidence to either reject the null hypothesis. If we reject the null, we see we have a statistically significant result, and that's associated with having a p-value, which is less than 0.05. So we are going to look at defining hypothesis testing in the context of an example. But a hypothesis test may be looking at just the relationship between one variable, such as treatment and the outcome. If we move this into multivariable statistical methods, this will allow us to control for other factors, such as potential confounders. So let me just ask, when I say the term multivariable statistical methods, what do you think of? What are some often used multivariable statistical methods? Anybody like to type that? So Zudi said linear regression. And so linear regression is when we have a continuous outcome. Laura's asking, can a randomized trial be carried out on different occasions or periods, or should all participants be included in the trial during the same time point? That's a great question. And I'm going to show this with an example using the example of ocular melanoma. But a randomized trial can actually be carried out over time. And so what we're hoping is that the randomized comparison remains the same across. So it does not need to be in the same limited period of time. Patients can be put into the trial at varying times over follow-up, over chronologic time. Right, and so Emma puts in multiple independent variable regression. And so that type of regression can be linear if it's a continuous outcome, logistic if it's a dichotomous outcome, or it could be a Cox proportional hazards model if it's a time to a dichotomous event. And so the type of analysis depends on the actual outcome of interest. And so there's many different kinds. We could talk about analysis of variance. We could talk about multinomial regression if we have a multi-level outcome. And so there are many different kinds of ways in which we can control through a regression model and also control for multiple variables and potential confounders. So I'm going to give you an example to tie some of these together in work that I actually did over a period of almost 20 years. And so ocular melanoma is a very rare cancer of the back of the eye, of the choroid of the eye. And the way I got involved in this is that there was a one-time study sponsored by our National Institute of Health, the National Eye Institute, and the National Cancer Institute to try to help ophthalmologists understand how to deal with a cancer when often they were not used to dealing with a life-threatening disease. So ocular melanoma only occurs in about 1,600 cases per year in the US, but it is a cancer that metastasizes to the liver. And so, it can be a very bad cancer even though it's a very rare cancer. So, there was a study that was conducted at 48 different clinical centers across the U.S. and Canada. Patients were actually recruited between 1985 and 2005 to look at the outcome of survival. And so all patients were recruited over this long period of time in order to get a sufficient sample size, and then they were all followed for 5 years to look at 5-year survival. So along the way, of course, we could ask, what are the baseline characteristics of patients treated for choroidal melanoma? These would be descriptive statistics. Is there a difference between two treatment groups with respect to 5-year survival? That would use inferential statistics. And then another question is, what are the risk factors associated, for example, with the growth of small tumors? So since this was a study that was only going to be conducted once, we actually had 2 randomized trials. One was for medium tumors, where the randomization was between enucleation or removal of the eye versus using a radioactive plaque to emit radiation. So it was a radioactive plaque secured over the sclera of the eye to see if that might decrease the tumor cells in the eye and still maintain useful vision. So that was for medium-sized tumors. For large-sized tumors, patients were randomized to removal of the eye versus having radiation therapy followed by removal of the eye. And the eye was enucleated for these large tumors because it was taking up such a large portion that the amount of useful vision was negligible. And then along the way, there was an observational study that was looking at small tumors over time. So this was not a randomized comparison. It was just an observational study looking at the progression of those small tumors. So there were many outcomes in the 2 randomized trial. Of interest was overall survival and metastasis-free survival, as well as in the medium-sized trial, years as well as both medium and large, overall survival, metastasis-free survival, years of useful vision. But the growth of the tumor was the outcome for the observational study of small tumors. So I'm going to use as an example then the large tumor trial, which was randomizing patients to either standard enucleation or pre-enucleation radiation therapy in order for us to look at the different characteristics at baseline in this randomized trial, where we would expect to see, relatively good balance between these groups. So let's look at them. I'm going to just annotate with a box. If we looked at age distribution, comparing standard enucleation versus pre-enucleation radiation, what do you observe? Good balance? Not so good balance? What's your impression? So I'd say, do you think the distribution by age is similar between these two groups? Right, I agree with all of you that are typing in relatively good balance. If we combined age groups, we'd see about 21% or less than 50 in the standard enucleation group, about 25% in the pre-enucleation radiation group. And similarly, if we look at older individuals, say older than 70, it's about 28% in the standard group versus 29% in the pre-enucleation. And we can look down and see fairly well balanced by sex, fairly well balanced by ethnicity, especially since this tends to be a disease which is in Caucasian individuals as opposed to non-white individuals. And then we can see, although there were the clinical centers, both in US and Canada, very well balanced in terms of country of residence as well. So using age as an example, we could look at, for example, a histogram here, which is looking at the age. So this is the distribution of age prior to treatment for choroidal melanoma. This doesn't correspond completely to the slide on the previous page, because you can see there are some younger individuals. There's also older individuals. These were not part of the actual study. But what do you notice about the shape of this distribution and potentially its central tendency? So, any observations regarding this distribution? Right, so you can see that it's not completely symmetric, right? It seems to be skewed, and so it's skewed to the left or negatively skewed. And so the reason I would say that it's skewed to the left or negative is that because the majority of the observations are to the right, and so the skewness we see is going to the left. We also see that the central tendency seems to be here in the 60 to 70 age range. And if we were to eyeball this with respect to the interquartile range, you would think about shaving off 25% on each side, and maybe the interquartile range is about 45 to 70. And Zudi, I agree, the mode or the most frequent age is in this, it looks to be about 65. So we might have some descriptive statistics in that way. We might also calculate from the data then that the mean age is 60.74. The minimum age is 12. The maximum age was 93 on that graph. And so the range would be a range of the max minus the min, or 81 years. The interquartile range, we'd actually have to calculate the 75th percentile, which was 69, and the 25th percentile, which is 50. So we would take the 75th minus the 25th, Q3 minus Q1, to get this interquartile range of 19 years. So that means that the middle 50% of patients fall in a range of 19 years. And then we could also calculate the standard deviation that goes along with the mean age, and see the standard deviation is about 14.5 years. So we start with descriptive statistics, but then let's move into estimation and confidence intervals. And I hope that by talking about this today, it will make it easier when you review statistics again tomorrow. But estimation is based on the fact that a sample statistic, like the mean age or the mean outcome, provides an estimate based on the sample of the unknown but true value in the population. And so the point estimate is the sample statistic, and we form an interval around that statistic called a confidence interval. And so often we use a 95% confidence interval that gives us a range of possible values for the truth that we don't know, based on the sample statistic that we've calculated from our study. So the 95% confidence interval allows us to say we're 95% confident that this interval overlaps the truth, which we are trying to assess. So you can think of a confidence interval as giving a range of certainty about the truth around that sample statistic that we calculate from our particular sample. So there are two ways to define confidence interval. One is that in theory, if we kept repeated sampling from a population, from the same population, and we can't do this in practice, but in theory, if we took a sample of size 200 from a population and formed a confidence interval around the sample statistic, and took another sample of size 200 from that same population, computed the statistic and formed the confidence interval, and did this in an unlimited amount of times, 95% of those confidence intervals would actually contain the true population value. So our interpretation for our particular study is that for one sample, there's a 95% chance that the interval contains the population value. So we at least have, if we set alpha equal to 0.05, then 1 minus alpha is 0.95. We have a 95% probability or chance that the interval contains the true population value. So let's bring this back to the choroidal or ocular melanoma example, in which we'll look at a particular outcome, and that outcome is 5-year survival after treatment. So 5-year survival. And if we looked at some values here, we could see that in patients randomized to enucleation, the 5-year survival rate was 57% or 0.57. If we formed a confidence interval around this, and we would take 0.57 plus or minus the tabled Z value of 1.96 times the corresponding standard error for the survival rate, we would get a confidence interval that ranged, we did get a confidence interval that ranged from 52% to 62%. So our interpretation is there is a 95% probability that this interval contains the true survival rate. So we're not saying that the true survival rate is in the interval. We're saying that the probability that the interval overlaps the truth is 95%. So we can see a fairly narrow range of that confidence interval in the enucleation group. If we look at the 5-year survival rate in the patients randomized to pre-enucleation radiation, we see that that survival rate is a little bit higher, so 62%. If we looked at the constructed confidence interval, it ranges from 57 to 66%. Our interpretation is still that there's a 95% chance or probability that this interval overlaps the true survival rate in the pre-enucleation radiation therapy group. So what do you notice about these two confidence intervals? If you were to compare the two confidence intervals, what do you notice? Okay, so Hala says they're close. And in fact, I agree with Anas and Zudi that we actually see these two confidence intervals overlap, right? They overlap quite a bit, which would suggest that there's no statistically significant difference between the two groups, right? So in seeing that overlap, here's the actual Kaplan-Meier graph that's looking at time to death. So starting at time 0, which is the year of enrollment for each individual. So the study was conducted over chronologically over 20 years, but each person has its own time 0. And so what we can see here is the cumulative probability of death from any cause in these two groups. So the dotted line is the pre-enucleation radiation therapy group. The solid line is the enucleation only group. And what would your conclusion just by looking at this graph suggest? Does there appear to be a difference in overall mortality between the two treatment groups? Or no difference? Right, so we'd say just by looking at this, there appears to be no difference. And we'll talk about statistical significance. So on the previous slide, we said the two confidence intervals overlapped, and that would suggest no statistical difference. But just in terms of looking at these graphs, we see these are very close. And so if the confidence intervals did overlap, we would say no statistically significant difference. And another way that we could look at this is to compute a risk ratio. So answering this question, is there a difference in survival between the two treatment groups? We could compute a risk ratio. So a risk ratio would take the overall risk of death in the pre-enucleation group compared to the overall risk of death in the enucleation group. We see that that risk ratio is 0.91. If there was no difference in treatment in overall survival between the two treatment groups, the risk ratio would be 1. So compared to 1, we see that actually there's a lower risk in the pre-enucleation group compared to enucleation. So this is less than 1. It's a 9% decrease. But importantly, to assess whether there's a statistical significance, we would see that the 95% confidence interval ranges from 0.76 to 1.09. So in fact, what would be your conclusion now? Is there a difference, a statistically significant difference in survival between the two treatment groups? And so, as Anna says, there is no statistically significant difference because this confidence interval crosses or overlaps the value of 1. And so since the confidence interval contains or overlaps the value of 1, we would say no statistically significant difference. Okay. So I'm going to just mention another test that can allow us to answer this same question. Is there a difference in survival between the two treatment groups? So there is a test that's used especially when we're looking at time to event data, so time to death, as we are in this case. The log rank test statistic allows us to test a null hypothesis that overall survival is the same by treatment versus an alternative that overall survival is different by treatment. So here we can introduce the value of the definition of a p-value. And the p-value in this case is 0.32, excuse me, indicating that there's no statistically significant difference between the two survival curves. And we would expect this hypothesis test and its conclusion regarding no statistically significant difference to correspond to what we just saw. So I'll take us back to the confidence interval for the risk ratio, which overlaps the value of 1, suggesting no statistically significant difference. So back to the log rank test statistic, we have a null hypothesis, we have the alternative hypothesis, but what does this p-value of 0.32 actually mean? So let's talk about that a bit. So a p-value is calculated by saying if the null hypothesis is true, that there's no difference in survival by treatment, in other words, survival is the same by treatment, the p-value under that assumption is the probability or the chance of observing the observed results, meaning our risk ratio of 0.91, the probability of observing those results when the null hypothesis would be that the risk ratio is equal to 1, that probability is 0.32 or 32%, meaning very likely. So let me ask, do you reject the null hypothesis or fail to reject the null hypothesis if you see a p-value of 0.32? So Laila is saying, no, we don't reject the null hypothesis. We fail to reject the null hypothesis. So Rasha, I would fail to reject. And Simon, we don't reject it. And so why is this? So let's talk about what the p-value is again. The p-value is the probability of observing what you did just by chance alone. And so if the probability is high, we fail to reject. If the probability is low, we would reject the null hypothesis. And the p-value is probably one of the most common statistical tools. There's been a push lately towards quoting confidence intervals, not just p-values, and I'm an advocate of not quoting just p-values. Some of the characteristics of a p-value is that they are frequently misunderstood, and sometimes they can be misleading because they're heavily influenced by sample size. So let's look at some statistically significant p-values. So when would you say it's unlikely that you would observe the results that you would expect under the null just by chance alone? So often this cut point, it's a rather arbitrary cut point, but often this cut point of a p-value being less than 0.05 says this would occur very rarely, only 5 out of 100 times by chance alone. A p-value less than 0.01 means it occurs only 1 out of 100 times. And a p-value that's very close to 0 means that this is so rare, it's less than 1 out of 1,000,000 times by chance alone. So we use this p-value to say that if a p-value is greater than 0.05, you're likely to see the results that you saw just by chance alone, and that supports the null hypothesis. If the p-value is less than 0.05, it's unlikely that you would observe your study results by chance alone if the null hypothesis is true. And that's where you would reject the null. So again, this should be used as a guide, not as a strict rule. It depends a lot on sample size, because if you have a large enough sample size, you can find any difference as being statistically significant. But if we go back to our observed p-value of 0.32, does it make sense that this would be likely to occur if the null hypothesis is true? So our risk ratio of 0.91 is likely to occur under the null, whereas if this p-value had been 0.01, then that indicates that the risk ratio is unlikely to occur if the survival is the same by treatment. And this is where we would reject the null hypothesis. So to expand a little bit on the correct interpretation of a p-value, it is giving us a crude measure of the weight of the statistical evidence we have to either support or reject a null hypothesis based on the data from our particular study. But it is influenced by sample size, and it's influenced by the amount of variability that we have between observations with respect to the outcome. So the larger the sample size, the easier it is to reject the null hypothesis. The small, as sample size decreases, it's less easy to reject the null hypothesis. So it does provide a form of reporting, but often decision-making has to go hand in hand with the confidence interval, not just the p-value. And so I've also put another bullet here to stress the fact that there sometimes is a difference between clinical or practical significance and statistical significance. And so can anybody give me an example of what I mean by that? Clinical significance versus statistical significance? So Anas is saying in the context of toxicity, so such as a cancer drug. Okay, so let me think then. So what we might think, this is an interesting example. If you have a cancer drug that might increase survival, right? So this is a very good point. You might see that your main outcome is survival. It might increase survival, but actually with a secondary outcome, such as toxicity, such as quality of life, those might be actually decreased. So that's a different topic than what I meant by this bullet, but this is a very good point. Mohammed says, well, the drug increases, survival by 5 years, but the mean age of death is already 85. So that is also a situation in which I think it would be involved more with the study design, right? That if you're looking at older individuals and have a somewhat unrealistic outcome of, looking to increase survival in a very, in an elderly population, that might actually be a misuse of resources in conducting a study. Bushra is saying we need a p-value of less than 0.05 to consider statistical significance, but less than 0.01 to consider it clinically significant. So actually, it's the reverse. When we think about it often, what we're thinking about is that we might not have a statistically significant difference. So in other words, suppose that the assumptions that you used for calculating your sample size were ones that gave you a smaller sample size calculation than what you would need to detect a statistically significant result. So in other words, I'll use an example of, suppose you have treatment A versus treatment B, and we're looking for symptoms to be decreased, and you see that there is a difference of 2 days in terms of the point estimate in the difference of symptoms being present for a particular disease, and it's not statistically significant, but suppose that that disease is diarrhea, and for the patient it would make a difference to have a 2-day difference. That might be one in which it's a clinical or practically significant difference, but not statistically significant. So you might see that it's not statistically significant, but it could be in a practical sense. And what often happens when you have a situation like that is there may be an additional study with a larger sample size to help confirm that there is both a practical and a statistical significance. But great discussion in the chat about how there could be situations in which you actually see a statistical significance difference in survival by 2 years, but it's at an incredible cost per year per patient. And then Zudi says we get a statistical significance in decimals due to large sample size. So I think what you're saying is we might actually see the reverse, which is that we see a highly statistically significant result, but it's so small in a clinical or practical sense that it's not meaningful. So great discussion, everyone. You certainly have brought up a lot of topics that you can have statistical significance that's not practical, or you could have practical significance, which is not shown as statistically significant. So going back to this example, when we ask this question, treatment or when we ask the question of is treatment associated with survival, for example, when we see something quoted like this in a journal article, treatment is statistically significantly better than placebo, p less than 0.05, it means that there was a study that was performed to compare treatment to placebo with respect to some outcome, such as survival. The null hypothesis is that survival is the same by treatment. The alternative is that survival is different by treatment. So if we see a p less than 0.05, this would suggest the study results in a better outcome with treatment than placebo. And we're asking the question, could this observation be a chance occurrence? Could we have seen treatment being better than placebo just by chance alone, but we're using this arbitrary cutoff of p less than 0.05. If the treatment is not effective, then there's less than a 5% chance of observing the difference in outcomes between treatment and placebo that you observe in your study. So based on this p less than 0.05, we'd reject the null, conclude that treatment is significantly better than placebo. So to just spend a little bit of grounding in sort of the foundational concept of sample size, we're typically asking what sample size, what n, is needed to ensure we have adequate statistical power to detect. And detect means identify as statistically significant a relevant difference in outcome. Tied along with that, we either set the power, or if we have a given sample size, we ask what statistical power is available. And we're interested in defining from the outset what difference in outcome is meaningful so that we're interested in detecting it as being statistically significant. So I could spend a whole hour talking about sample size, but let's just spend a few slides talking about it. So what are the ramifications of inadequate sample size? So one we talked about already, that an effective therapy may not be discovered, in other words, identified as being statistically significant. And so this would be a ramification of not identifying an effective therapy, not putting it into practice. Or we might have an inappropriate interpretation of a negative result. This was the situation in which we might not see a statistically significant difference between two treatments, but it's actually meaningful in a practical sense. So here's just a graph to try to put a few of these items that are needed for sample size together. So in the collaborative ocular melanoma study, we looked at what sample size was required to detect specific differences in mortality between the two treatment groups at 5 years, and made some assumptions. So type 1 error of 0.01, this is a small, it's less than 0.05. So we knew this study was only going to be done once. So we set alpha, so I'll animate in, alpha is 0.01. That's the probability of rejecting the null hypothesis when there's really no difference. We looked at type 2 error of 0.1, that's beta. Beta is the probability of not finding a difference when there really is one. And what we wanted then was high statistical power. Power is the ability to detect a difference or reject the null hypothesis when there is actually a particular difference in 5-year mortality following from across time. So in this case, we were looking at 5 years as the point in time, and you can see what happens to the sample size. So if we wanted to detect just a large difference, meaning a 50% difference in mortality at 5 years, we would need less than 500 sample size per group. If we wanted to detect a 30% difference, we again would need less than 1,000. But what happens if you want to detect a 15% difference, so a smaller difference in 5-year mortality between the two treatment groups? So what you can see is actually to detect a smaller difference, we need a larger sample size. This is showing over 2,000 per group. What if we were interested in detecting a small difference of 10%? We'd need 6,000 per group. So let me pause for a second and ask if there are any questions about this. We set the two types of errors, alpha and beta. We indicated that of interest to us was a 25% difference in mortality at 5 years. So that meant we needed about 1,000 patients per group. But if we had been content with detecting a 50%, a large difference, which might not be practical, right, might not be typical, we wouldn't need a large sample size. But if we wanted to detect a 10% difference, we'd need a very large sample size. So let me just see if you have some questions regarding the great question. So Almothana is asking, on what basis do we choose alpha and beta? And so these are the types of mistakes. Remember, these are the errors we can make in our decision-making with hypothesis testing. So type 1 error is rejecting the null hypothesis when it's true. Type 2 is failing to reject the null hypothesis when the alternative is actually true. So the two types of errors we want to be small, but typically the type 1 error is either 0.01 or 0.05. Those are typical values. We also want type 2 error to be small, typical values are 0.1 or 0.2, which means if we take 1 minus beta, the power would be either 0.8 or 0.9. So we want power, we want to have a high probability of detecting a difference when it actually exists, but we want to keep our mistakes in hypothesis testing low, and that's what alpha and beta are. And so by having a low beta, we would have a high power. And so, to specifically answer Almuthanna's question about on what basis, we chose in this study an alpha of 0.01 instead of 0.05, simply because we knew that this was a very long randomized clinical trial, probably not to be repeated again. And so we wanted to minimize this type 1 error by setting it to 0.01. But again, often 0.01 or 0.05 are for type 1 error, 0.1 or 0.2 for type 2 error. And the difference in mortality we were looking for was 25%, but you could see as an investigator, you'd have to make a decision on what is meant to be a meaningful difference in mortality at 5 years between the two treatment groups. Okay, any other questions about sample size, alpha, beta, power? But just to re-emphasize that since we set our sample size at 1,000 in each group to detect a 25% difference, that would have allowed us, if we had observed a larger difference, we would have detected it as statistically significant. But what would have happened if we did the study and observed that there was a 20% difference between the two treatment groups? Would we have been able to detect that based on our sample size? While you're thinking about that question, I'll answer Bushra's, which is we minimized the type 2 error by increasing the sample size, right? So both the type 1 and the type 2 errors for other picked, selected differences in mortality would be able to be minimized by increasing the sample size. That's right. So if our sample size was decreased, it would increase our type 1 and type 2 errors. And Anas, thank you for answering the question that if we set our detectable difference to be 25, that means we have a sample size that would lead us to reject the null hypothesis if we saw a difference in mortality at 5 years of 25% or more, but we would not be able to detect a smaller difference as statistically significant. We would miss that. And that's right, Ashra. So let me just type into the chat as well, is that typically what we see is that type 1 is equal to 0.05 or 0.01, right? So that said of, but I should have said R, so I'm gonna or. So, right, so typical values, whereas typical values of type 2 error are either 0.2 or 0.1. And then that means that power, which is 1 minus the probability of a type 2 error, which is the same as saying 1 minus beta, is then either typically 0.8, so you'll see this in a second in the chat, or 0.9. Okay, so those are the typical values that we would use in medical or clinical research. Okay, so, well, I moved from that slide, but any other questions about sample size? So sorry, so I missed your question there before that. In clinical trials, so the issue, this is a great question. Is it better to have alpha equal to 0.01? And so typically you'll see 0.05. When you change it to 0.01, that sample size really increases. And so for this particular randomized trial, we chose to use 0.01 as the type 1 error, simply because we knew this clinical trial would never be repeated. And so because of that, we had a very large sample size of 1,000 in both groups in a very rare disease. So it took a long time to recruit patients and then follow them for the outcome of mortality. So what is good to do when you're doing sample size calculations is to calculate your sample size under different assumptions. So sample size calculation should never be just one number. You should really think of creating a table in which you vary the type 1 and 2 error, the difference in the outcome that you're interested in detecting, and see how that influences the sample size, because then what you'll be looking at is trying to balance your sample size calculation for a statistical difference versus the available resources. So how many patients might you have? How long would it take to recruit? What are the costs? If it's a very costly drug that you're investigating, all of this needs to be balanced between the sample size and the objectives of the study, whether it's for safety or efficacy, as well as thinking about or trying to estimate what proportion of eligible patients won't agree to enroll in the study. So it's a balance. It's a balance of the statistical considerations, the available resources, and then also making sure that there's some sort of study, a pilot study done initially, so that the results of that pilot study can help inform the considerations in sample size. So just going back to this graph, there had not been a pilot study of a clinical trial in ocular melanoma, but by looking at observational studies, certainly a 25% difference was deemed as being reasonable, as opposed to seeing a 40 or 50% difference. And so using the results of previous literature are always important in sample size calculations. Okay. And then there are problems in achieving planned sample size calculations. And some of that is balanced by the stringency or lack of stringency of eligibility criteria. So if your eligibility criteria are too stringent, too strict, you could have a very small pool of patients. And you also might see the proportion of eligible patients who don't enroll is large. We also have to be concerned with non-compliance with treatment and losses to follow-up. And so just looking back at the chat, so Zudi has asked, how can I calculate the sample size when there aren't previous data or studies? Excellent question, Zudi, and that I can see happening in a lot of places. But my recommendation when you have no prior data is to make some assumptions about what could be a meaningful difference. So if you are comparing group A versus group B, you could look at a different range of differences and actually see how you might be able to balance your sample size with, different assumptions about what is a meaningful difference. So sometimes you have to do a pilot study in order to actually have some data to go on to put into your sample size calculation. So I would certainly not go with a randomized clinical trial without having some pilot data. And then the sample size that's best, is there any rule? Sometimes struggle to achieve the required sample size for the main study. Yeah, so the sample size for piloting, Suha, is one in which you might start with a sample size that's, you know, sort of 25 or 30 and try to get at least an estimate of the outcome, right? An estimate of the outcome in one group and possibly in the other, in order to be able to have some realistic assumptions in your sample size calculation. Oh, and then Sue is asking, is it appropriate to use the pilot study in the final analysis? So, you know, I have seen situations, and I would advocate if your pilot study actually looked at the same outcome and was the same eligibility criteria and the same procedures, one can use the pilot study as the beginning of the actual continued, you know, final project. But often pilot studies are important in terms of helping us understand whether or not there should be changes made before doing the final study. So it could be that the eligibility criteria are a bit different in the pilot study. It could be that the measurement of an outcome is a little bit different. And so, so I'd be careful in using the pilot study data in the final analysis unless it's the same. And then the Lorentz formula, I'm not sure about the Lorentz formula and which what is meant by that. I thought at first some of you were asking about, are there some kinds of programs that you can use for sample size calculation? And there are some freely available programs. I'll just put in the DuPont and Plummer sample size calculation. So this is a free sample size, I will call it, you know, a downloadable freeware. But I'm not sure, I'm not sure about the Lorentz formula. So sorry, Nellie, if you have another question about that. Okay. Well, so in terms of our last conclusion about sample size is that, as we've mentioned, a sample size that's too small may result in a non-significant finding, even if there appears to be a real or practical difference. And a statistically significant finding may result from having extremely large sample sizes, even if the finding is not clinically meaningful. So very important for us to keep that in mind. And then just one slide on statistical methods, where you will see this a little bit more, I think, tomorrow in terms of looking at relationship between one variable and an outcome. We can use z-tests or t-tests or chi-squared. We mentioned multivariable methods, looking at the relationship between two variables after adjusting for other variables, and linear regression for continuous outcomes, logistic for dichotomous outcomes, and Cox proportional hazards model is for looking at time to an event, like time to death, which is a dichotomous outcome, comparing, say, two treatment groups. So I'm going to end here with just some comments on what then do you do in terms of both how can we think about the components of a good clinical research study? I hope that we've talked a bit today about the quality of the study design, the conduct, the data, and the methods of analysis. But what's equally important, and sometimes more important, is the completeness of the reporting of the study design, the conduct of the study, the data that collected, and the the methods of analysis. So in these last few minutes, in terms of study reporting guidelines, this website actually shows study reporting guidelines for a number of different types of study designs, seen here on the right-hand side. And if we clicked on randomized trial, we would see that the consort statement is a checklist for updated guidelines for reporting two-group or parallel randomized trials. And so this is important because it gives a whole checklist for the title and abstract, the introduction, what should be in the methods section, the results, and the discussion. And this allows the reader to actually see the quality of the study design, the quantitative methods and the results, and actually whether or not they would whether or not the discussion is listing both the limitations as well as the strengths of the study. So these consort statements for randomized clinical trials provide a checklist and a flow diagram for reporting a trial. It's actually been adopted by many major medical and healthcare journals as checklists that have been used since the 1990s. And these types of reporting guidelines have really helped improve the quality of the reports of randomized clinical trials and other clinical research designs. So I'd encourage you to go to that website and look at these different types of reporting standards for different types of study designs. So I'll just conclude then in terms of hoping that we've gone through some of the steps in conducting clinical research, as a review a little bit from what you saw yesterday, the fundamentals of good quantitative research study designs, the importance of identifying data that need to be collected, trying to minimize missing data, identifying eligibility criteria, et cetera. And then we spent some time on statistical considerations using the example of the ocular melanoma, where we looked at sample size, we described some descriptive statistics, and we also reviewed some inferential statistics with confidence intervals and hypothesis testing. And then we ended here on reporting, the importance of reporting and dissemination of results in a high quality way that then can allow us to see the implementation of those results into practice. So that takes us to this last slide. I know you have another lecture coming up, but I think I still have time for a few questions, and I can see a question on blinding. And so blinding or masking means that there is there is a randomization procedure that takes place without, so the first part of the masking would be that neither the clinician nor the coordinator nor the patient knows which treatment they're going to be given. The most common use of the term blinding is that if you have treatment A versus treatment B, and they're both drugs, for example, you might have treatment versus placebo, you would try to have those packaged or those pills to look the same so that the patient does not know which treatment they're receiving. So the investigator is masked to the treatment, the coordinator or the study manager is masked, and the patient is also masked or blinded to that treatment. And so the term blinding is the same as masking. Sudi, thank you for putting that web link in. I will send along two things. One is a PDF of the consort guidelines, as well as, but now you have the website, which is good, as well as my slides, so that those can be posted along with the recording. So I'm hoping that I answered that question about blinding or masking, but that's often to decrease bias with respect to the patient report of, say how they're feeling. Often if there's an assessment of some sort, it's best that the assessor does not know what the treatment group is that a patient has been randomized to. Right.
We still have, oh,
Go ahead.
I was going to say we still have about 5 minutes. So if anybody wants to ask a verbal question, please raise your hand and I will send you a request to unmute yourself. Thanks.
Great. Thank you, Toria. Yes, if anybody would like to ask a verbal question, that would be super. Well, I appreciate all of you being here and for all of your interest. And what we heard at the beginning, so I'm just a proponent of the organizers, that it seems like in about 2 weeks, the recordings would be made available to everyone. If I send my actual PDF files of the lecture, would those be also posted, Laila?
Yes, we are going to have about a runtime of about a month while we set everything up for everyone to access, and they will get an email instructing them on how to access the recordings and any materials that the lecturers provide.
Super.
Yes, absolutely. So in a couple of weeks, hopefully we will send everything to everybody. So, inshallah.
Yeah, really a wonderful large group here. I had no idea how many busy, clinicians would come to this 3-day workshop. Maybe by a show of hands, just electronic hands, how many of you are physicians? I'm assuming that most are, okay, and medical students as well, right? I saw that medical students, clinicians, imagine, yeah, so a number of medical students. So I think ranging from medical student through to physician, nurses, etc. Have a really great group here.
Among our registrants, we have about 2/3 medical students and
Wow.
1/3 between physicians, faculty, and different healthcare providers, including nurses and pharmacists. So we have a very nice, excited audience.
Yeah, oh, that's wonderful. That is wonderful. Well, I'm very sorry that I couldn't be in Jordan with everyone today, but I'm glad that I could be with all of you electronically. And I wish, we certainly have been thinking of all of you as we are here in the United States on a daily basis, actually. So hope all is going as best as can be.
Thank you. Thank you so much, Dr. Mary. This has been amazing. It's a beautiful overview from the ABCs to more advanced look at research and data, from descriptive to inferential, and then to examples on the application of inferential statistics. So this has been really fantastic and much appreciated. And we hope to see you, inshallah, soon in Jordan. We want to extend collaboration, and we'd love to collaborate. I know the Middle Eastern population is underrepresented in clinical trials. So perhaps this is a first step to be engaged more and more in clinical trials, maybe multi-center trials. We're creating a culture interest in research so that we can move forward. And thank you so much for everything. And thank you for thinking about us, and keep us in your prayers.
I will. Well, thank you so much for having me, and I really appreciated everybody's cooperation and interaction today. So, best wishes for the next day and a half of the workshop, and I'll look forward to hearing updates on how everything turned out. So, thanks again.
Thank you so much. Any questions for Dr. Mary?
Well, seeing none, thank you everybody for all of your comments in the chat. And I guess you get to take a 5-minute break because then you have another lecture coming soon.
Yes. Thank you so much, Dr. Mary. Thank you.
Yeah, thank you.
And God bless.
Thank you. You too. Bye-bye.
We have a few minutes of break. I will share again the QR code for the pretest. And like my colleague, Dr. Salame said, we would like to gather this data, and number one, to improve ourselves, and number two, to give us ideas for future workshops based on the request of the audience. So I'm going to post it in a second.
Does the iPhone user have a question?
Hi, Laila. Can you hear me?
I can hear you. I don't know if Laila can hear you.
Hello, yes, I'm trying to share my screen. Hello?
Yes, it was a great talk.
Oh, it's Dr.
by
Yaser.
Yeah.
This is Dr. Yaser, the Dean of our School of Medicine. Welcome, Dr. Yaser.
Thank you, Laila. It was really a great talk by the professor. I see that, I was very interested to see how many participants are there. And believe it or not, over the past 2-hour talk or 2.5-hour talk, but how long was the talk? Was it 2.5? I did not even know how long the talk was. It was so interesting that, time just lapsed very quickly. It was a great comprehensive topic that the professor went all over, the details of how to starting from design, going through the didactics of research. I see that most of the students were there all through. Their number was ranging between 330 to 350. A lot of people, are sharing us from different universities as well. So I'm sure that what's coming is going to be more and more interesting. And so let's keep it up. And I hope this number just goes up more and more.
Hopefully, yes. We would like this information and the knowledge to disseminate to the greatest number of people, inshallah.
I do agree with you, Laila, that, the Middle Eastern population is underrepresented. And this is an opportunity for us to get engaged more in, international research and more collaboration in the future.
Absolutely.
Although at the Jordan University Hospital, we are, participating in a lot of clinical trials. I myself have 6 clinical trials, international clinical trials in inflammatory bowel disease. But I do agree with you that we need more engagement in international research.
Inshallah, hopefully. It starts with a paradigm shift in the culture, especially the culture of the participants who are usually afraid to engage in clinical trials.
Agree.
So Dr. Ming Young, it is a really honor and a pleasure to introduce Dr. Ming Young, who's the senior editor of Nature Medicine. Dr. Ming completed his undergraduate degree in physiology at the King's College in London, followed by a master's degree in pharmacology at the University of Bristol. And he completed his PhD and postdoctoral research at the University of Cambridge, where he investigated the effects of metformin in the GI tract and the functions of the enteroendocrine cells in the context of metabolic diseases. And during his PhD, he did a secondment at the Science magazine and Science Translational Medicine. And he was an editor in the BMC Medicine in 2020 before joining Nature Medicine in March of 2022. And he handles papers in the areas of non-communicable diseases, public health. And he's currently based in the London office. So it's an honor and a pleasure to welcome you, Dr. Ming.
Thank you so much, Laila, for the kind introductions. And it's really an honor for me to give this presentation to the 335 and counting participants in the into this talk, and I hope that you'll get something out of this. And so I sort of so as Laila introduced, I am the senior editor and I handle research papers in public health and non-communicable diseases at Nature Medicine. I've been working as an editor for about 3.5 years now, and as you may or may not know, Nature Medicine has experienced quite a big transition, and it is a leading medical journal in the areas of clinical medicine over those past 5 years. And yeah, we're interested in different aspects of clinical research and public health. And so I thought that I would like to give this talk today about an overview of the medical publishing process. And hopefully you have some take-home points to consider when you start designing a research study, as well as preparing a manuscript for publication. So the objectives of this webinar are to consider why is publishing important and the impact of local and global health publications, the different types of research study designs, the editorial process and what editors consider in papers, whether it is research papers or whether it is non-research content. Also, I'd like to discuss as well the best research conduct and reporting practices for clinical research, as well as finally choosing the right journal. So first of all, I want to discuss about why medical publishing is important and the impact of publications. So medical journals serve as the primary means to share and disseminate new findings and discoveries, and they are the venues to advance knowledge in various fields of medicine, whether it is nursing, clinical medicine, or public health. They also serve as means of discussion and debate of timely medical topics, hypotheses, and questions. All medical journals, all legitimate medical journals, I would add, have a peer review process. So they are what is the quality control process to evaluate the quality and the validity of research before publication. And they provide credible evidence-based information that informs clinical practice, healthcare guidelines, and public policy. So I want to give one type of example of how medical publications are the means to provide evidence that informs global policy. And for example, we have recently published a study which reported the estimates of heat-related mortality in Europe during the summer of 2022. And this study was used as the evidence base as a reference study for the OECD environmental policy papers, which OECD is an intergovernmental economic organization involving 38 member countries, and this is a policy. They're developing an environmental policy that links with the economic aspects of the organization, and another example is that we also published the modeling evidence behind the recent WHO guideline for screening and treatment of cervical cancer. So all of these guidelines and recommendations for, from the regional and international levels, they need the evidence base, the scientific evidence base that forms the basis to provide the recommendations. And this is really one examples of the impact of publications in providing that evidence base. I also want to emphasize here that it is not just about global modeling studies as the only means to have impact in policy. Local health research does as well. So as you may have heard of, the local health is global health. And this is, and I guess two of the best examples I can give. One is the friendship bench. So this friendship bench is a mental health program that was started in Zimbabwe, in Harare, Zimbabwe, where grandmothers served as talk therapists to treat people with mental health conditions. And now this friendship bench intervention has now been rolled out in 4 African countries. And also they are piloting this intervention in Washington, D.C. Another example is a cluster randomized trial looking at clinical breast examination that's done in Mumbai, India as a means of breast cancer screening. And the results from this trial provides the evidence base for the most recent WHO Global Breast Cancer Initiative implementation framework. So as you can see here, these are studies that are done at the local level, and they have the potential to make an impact on global recommendations, or even making the interventions spread globally. So these are some of the examples of research that can have an influence and impact at the global level. And so, but I think we want to sort of take a step back first and talk about, well, get back to the basics and talk about what are the different types of research out there, and the different types of publications. So first of all, as you may know, most medical journals have a research, publish both research content and non-research content. So research articles disseminate research findings and new discoveries. They are always peer-reviewed. They typically follow a specific structure, including introduction, methods, results, and discussion. And then there are magazine and non-research content. They are largely commissioned. They provide an overview of recent advances in the field. They can raise a personal viewpoint, an opinion, or debate. And different journals have different formats, and it really depends on the journal. So they can range from literature reviews to correspondences to opinion articles. So when it comes to case reports, or sometimes you may see as small case series, these are a detailed report of the diagnosis, treatment, and the follow-up of an individual patient or a small number of patient cases. And they generally include also the demographic and the clinical information about the patient. And you can see that even the leading medical journals will publish case reports, like the recent case report of a death after gene therapy in a patient with Duchenne muscular dystrophy in New England Journal of Medicine, or a case report of one of the first cases of a pig to human cardiac xenotransplantation, which was published in the Lancet. When I just joined, I heard that there was a discussion about clinical trials. So I'm assuming that all of you, or most of you, will be familiar with clinical trials. And clinical trials are any research study that prospectively assigns human participants or groups of people to one or more health-related interventions to evaluate the effects on health outcomes. So they can range from small clinical trials like phase 1 trials, or to a more advanced trials like phase 3 trials, as you can see as recent study in Lancet Hematology here, looking at I think hypoxia as primary stroke prevention in Nigeria, or they can be a population trials. So these include cluster randomized trials, which are done across several healthcare facilities, or for example, delivering an intervention like a salt substitution intervention across populations. They can also be done in villages, in hospitals, etc. But the key with the population trials is that it's done across multiple facilities. And then there are qualitative studies. So these are any research study that involves interviewing or surveys on participants to gather non-numerical data and to look at the perceptions about a particular clinical research question. There is also mixed methods, which are reporting of both qualitative and quantitative findings. And then there are observational and epidemiology studies. So these are systematic observation and analyses of individuals in real world or natural settings without any intervention by the investigator. So these studies can be specific to a particular region, like a recent study published in the Lancet Global Health looking at neonatal mortality due to the war in Tigray in Ethiopia, or a national study like a genetic epidemiology study looking at the risk of cancer in different ancestries in Qatar. Or that they can be entirely multinational, like a study we have published looking at the risk of type 2 diabetes due to suboptimal diets in a study including 184 countries. So the biggest factor about epidemiology studies is that they draw associations. They do not imply or infer any causation to the findings. And then there are systematic review and meta-analyses. These are evidence syntheses which involve examination of data from a number of independent studies of the same subject or topic. This is done through a systematic literature search. The findings can be qualitative, as in the case of a systematic review, or quantitative, as in the case of meta-analysis. And then there are biomarker studies. So these report a characteristic that is objectively measured and evaluated as an indicator of either normal biological processes, such as a response to diet, or indicator of disease states, like markers associated with pathology of Alzheimer's disease, or pharmacological responses to a therapeutic intervention, like biomarkers of response to targeted therapies for lupus. So now you kind of got to get a flavor of the different types of clinical study designs. So I then want to discuss about what editors look for in the manuscript. So this is a really, really simplified overview of the editorial process. And this is really the different roles of the editors in the publication process. So as editors, we read new manuscripts, we make editorial assessments, we make pre-peer review editorial decisions, and we discuss transfers with other journals. In the peer review, if we do decide to send the paper out to peer review, and I'll talk a little bit more about that, we manage the peer review process and we find external reviewers to evaluate the work. And after we get all the peer reviewers' reports, we assess the reviewers' reports. We make notes of the main key things about the peer reviewers' reports. And then we often discuss as a team. And if we make a decision, we write the decision letters. And if we, many times we do make a rejection decision after peer review. or if we revise, then we work with the authors to improve the paper during the peer review process. And as I mentioned, we often reject papers after peer review, and we discuss transfers to of the paper to another journal after peer review, and also we deal with any appeals to the rejection decision. And if after multiple rounds of the peer review process, if we are very interested in the paper and the paper has gone a long way since the start of the peer review process, we would issue a decision called an accept in principle, or it's known as AIP. And this is where we perform things like editorial checks to make sure that everything is there, the formatting is okay, the ethics is completely sound, and data and code availability. Just these are the final checks that we make to make sure that the study adheres to the journal policies. We sometimes make edits to the manuscript to check the language, make sure that it is patient-centric, and also remove any overstatements and conclusions that are not supported by the data. And also, I want to emphasize here that the procedures are very different between different journals. So in some journals, editors discuss more with other editors before the peer review process, and in others after peer review. In clinical journals, for example, there is a lot more team-based decisions and working as a team, whereas for the basic sciences, it's more independent. I then also want to make a distinction of what editors and what peer reviewers think about when they look at a manuscript. An editor, first of all, we have a lot more responsibility for the journal. We are responsible for what we publish, and if there are any issues, we are held accountable for what we publish. We also look at the paper from a big picture perspective. Is the paper right for the journal? And we also look for conceptual novelty, the journal, whether the study adheres to the editorial guidelines and policies, and if there are any major technical flaws. The peer reviewer is essentially like an advisory role for us, and we take their comments into account. And it is also important for the authors to address the peer reviewers' comments. But peer reviewers, what they are asked to do is to assess the technical aspects, the experimental design, conclusions drawn, statistical analyses, etc. How we ask the peer reviewer to really assess whether the paper would advance the field that they're working on. And also to another thing I didn't put down was that we also look for local peer reviewers who are based in the region who can comment on the context of the work and whether the context of the work is important, whether it is discussing the local context and the local issues of the region. And the peer reviewer provides a recommendation and not the final decision or the initial or any decision to the paper. And they only provide the recommendation. So what are the editors looking for in a research paper? The most fundamentals are whether the paper adheres to journal policies. These are the editorial values of publishing in a journal. Registration, reporting, and ethics practices. The methodology and robustness of the findings. Are the conclusions strongly supported by the data presented? The appropriateness of the research paper for the journal. So is the paper a good fit to the journal? And the conceptual aspects, such as novelty, impacts, and the implications of the work. And I will discuss most of these points in the later parts of the presentation. I also want to dispel some common myths about what people think editors consider in terms of clinical and health research. There's a myth that we only look at how well a paper is going to be cited, and that the impact factor is all that matters. And I cannot disagree with that myth more, because we look at a research paper in different ways. For example, if it's a local research, we look at whether whether it is done in a local context, and whether it has the potential to change practice and improve lives. Another myth is that we prefer studies coming from high-income countries, and as a public health editor, I actually like to champion more representation of research from low and middle income countries and in unique settings that are understudied in many parts of the world. That the study has to have perfect English language. We work with authors if there are any language barriers, especially many of you who are writing research in English, there will be language barriers, and we will work with the authors if the research is within scope and of interest. And if the studies have only positive findings, and I've recently published a paper that is completely a null finding. So we certainly consider research that has null and negative findings. So let's move a bit out of research. So what about reviews, commentaries, and perspectives, so the non-research content? So they are the means to discuss recent developments in the field and provide a point of view or means of discussion, which I think I mentioned before. So what I would suggest is that if you are interested in writing a commentary or perspective to submit to a journal, write with a big picture in mind. So how does the piece appeal to a broad medical or public health audience? Local issues matter. So discuss a topical issue that is unique to your region, and provide a perspective or a development that is unique. So tell your story. So we have, for example, published commentaries and correspondences. For example, recent correspondence that is discussing a capacity building program to enhance the digital literacy of mental health care professionals in West Africa, or a correspondence discussing the issue that Pakistan is failing in meeting the targets for maternal and neonatal tetanus elimination. So certainly regional issues are important. So I also want to discuss about the best research conduct and reporting practices. So it is essential that if you start doing any type of clinical or human-based research, that they must have been performed in accordance with the Declaration of Helsinki. So at the Declaration of Helsinki is a set of ethics principles that needs to be adhered to for any type of medical research involving human participants and patients. So an important part of the declaration is that the research must comply with local, national, and international regulatory standards. The ethics committee has been involved in approving the research. So when you write the manuscript, please enclose the name of the ethics committee and the Institute Review Board number to be identified. And that the papers must also include an informed consent statement. So have you sought consent from the participants or patients involved in the research study? Also, another important aspect is to register your study protocol. So preparing your clinical study protocol and making it available to either database or registry is essential before you start conducting a clinical study, especially clinical trials. And this is to ensure the transparency of the entire clinical research process. So for clinical trials, all medical journals expect that your study is registered in a WHO-approved clinical trial registry, like clinicaltrials.gov or one of the approved registries. Many journals, including Nature Medicine and other journals within the Nature portfolio, expect the clinical trial to be registered before the trial starts recruiting participants. And this is called prospective registration. So what prospective registration means is that if you see here, this is the clinic on the left, this is the clinical trial registry. And you can see that there's a date of the registry, and that's the date of registration of the trial protocol in that registry. And then when you start the study, the date needs to be after you register your study in the trial registry. So as you see here, that was the same study, and that was that started recruiting participants on the 1st of July 2021, and it was registered in 22nd of January 2021. And that is prospective registration. Also, as I alluded to, different study designs need to adhere to specific reporting guidelines. So adhering to reporting guidelines are important to ensure the transparency of the entire research process. Particularly, consult reporting is essential for clinical trials, but as you can see, there are guidelines for case reports, biomarker studies, observational epidemiology studies, systematic reviews and meta-analyses, etc. So I suggest that you check out the Equator Network, and that has the checklist for all of those reporting guidelines that you can download. And following these guidelines actually help with you structuring when you write the research paper. So another key issue is reproducibility. So academic journals have specific policies to improve the reproducibility of scientific and medical research. And as you can see here, that there is a kind of a replication crisis, that most of the research studies that are being published cannot be replicated by their peers. And so as journals, we have the responsibility to enhance the transparency of the research to ensure that they are reproducible. So examples of that include data and code availability. So making the data available by depositing data into a public repository or providing information on any restrictions to data access. Prepare a study protocol. And this is a must for clinical trials, as I alluded to earlier, and make them publicly available, or at the very least to the peer reviewers. Ensure that there is sufficient methodological details in the paper that can be reproduced by other researchers, especially statistical analysis. Also, many journals have policies on data presentation. So, for example, some journals will ask that or encourage or recommend that you present the data as separate data points as opposed to averages. And so this is really an example of data presentation policies that many journals have, including Nature Medicine. So I also want to mention there are some nature-specific editorial policies. So, for example, we have recently adopted the SAGE guidelines, which is a guideline for the reporting of sex and gender human participants in research. We also have an advice for the reporting of different ethnic groups in all domains of scientific and medical research. And also, we have recently a guideline for global health research. This is called the Equitable Partnership Policy. And this is a framework for all types of studies involving local health or global health research that are or any type of inclusive research in understudied populations. So the reason to have this policy is to support collaborative efforts and building research capacity in studies done in under-resourced settings or in unique settings, for example, in the Middle East. And so what we ask for in research studies done in these settings are a disclosure statement on inclusion and ethics. So how has the local researchers been involved in the study design, the data analysis, and the manuscript writing, and whether the research is locally relevant. And also we ask that for any research that is done in these settings, that the local contributors are acknowledged as co-authors for the study, as well as we also encourage the researchers in the paper to cite local and regional research to support citation diversity. And so these policies, including equitable partnership policies, this is really an example of the value of medical publishing, because reinforcing in these initiatives and editorial policies are the means to influence and encourage the field towards more equitable, fair, and ethical research practices. So I think finally, I want to discuss about targeting the right journal. So the biggest reason for the rejection of a paper by a medical journal is that the study is outside of the scope and interest of the journal. So at Nature Medicine, for example, we only send out 15% of submissions out to peer review. And a lot of the papers that were rejected before peer review were outside of the scope. And what I mean by scope is that, for example, different medical journals have different priorities in what they publish. So some medical journals do not consider a particular type of study as they are outside of the scope. So for example, BMJ, a British medical journal, publishes lots of systematic review methods and journalology, and we rarely consider these in Nature Medicine. So one advice I could give to you in this workshop is to please review the journal's aims and scope, and also look at their most recent publications to get a sense of their interests. And you can, I'll give an example of Nature Medicine here. You can see that we have a dedicated web page on the aims and scope of the journal. And we consider almost all types of clinical research, as I mentioned before, case reports, clinical trials, observational studies, meta-analyses, biomarker studies, global health studies, etc. And we rarely consider, for example, clinical trial protocols, qualitative studies, method development papers, biological or physiological sciences, like studies done in zebrafish, mouse models, cell lines, etc. So you can always check out the journal's aims and scope before you consider submitting the paper to the journal. And different clinical research journals have different interests and priorities when considering different audiences for their publications. So at the Nature research journals, we have a hierarchy of journals such as Nature and Nature Medicine at the top, followed by the Nature research journals like Nature Cancer, Nature Mental Health, which are sort of specific to a particular discipline. And then we have the open access journals like Nature Communications, then the communications journals like Communications Medicine, and then finally scientific reports. So the highly selective journals like Nature and Nature Medicine, we consider two things: the breadth of readership and the novelty or impact of the research. Whereas the least selective journals like scientific reports are sound science journals where the novelty and impact is not a criteria for consideration. I'm not just talking about Nature research journals as well. There's also a hierarchy of journals within the clinical journals ecosystem. And I'll give you an example of the public global health field. There's the top medical journals like the BMJ, Nature Medicine, the Lancet. Then there is the top specialty journals like, for example, the Lancet specialties like the Lancet Global Health. Then there's the broad open access journals like Lancet Regional Health, Nature Communications, PLOS Medicine, JAMA Network Open. And then at the bottom, there's finally the specialty journals in the global health field like BMJ Global Health, PLOS Global Public Health, JCO Global Oncology. And the principles are the same: breadth of readership, as well as the novelty or the impact of the work. I'll give you an example of a study that was from the same authors, of two studies that were from the same authors, but they ended up in different journals. And I'll give an example of cervical cancer. So a study that we have recently published in Nature Medicine is a study that is a cluster randomized trial looking at the delivery of two community integrated HPV-based cervical screening interventions in Uganda. And then there's a study that was published in PLOS Global Public Health, which is also in cervical cancer, and is also done in Uganda. And that is looking at the economic burden of cervical cancer in two public cervical cancer clinics. So these are the similarities of both papers, are that they are on the topic of cervical cancer. They're both done in Uganda. But the difference here are the potential impact and appeal. The paper in Nature Medicine was a prospective trial. It's about looking at the delivery and the implementation of two novel interventions. And these interventions have been integrated into community healthcare systems. And the second study is focused on economic burden, and it can have an impact on the local policy perspective, done in similar contexts, but it is valuable probably to a more targeted audience who are interested in health economics and local health policy. The second difference are scope. For the Nature Medicine paper, it's broader and encompasses more wider rural regions from multiple villages involved in the trial. Whereas the second study had the scope is only in two cervical cancer clinics involving a cross-sectional design. And I kind of give this example here so that you can get a bit of an idea of how we look at papers when we, in terms of the scope and the impact and etc. on the same, or even on studies from on the same topic. So how can you broaden the appeal of your work? So first of all, think about the scope of your study and the audience that you're writing for. Is it for a general medical readership, or is it for a specialty audience? When you think about the title of your study, make it clear and succinct. Avoid questions, avoid puns, avoid metaphors. We editors are not interested in any of that. Write with a logical structure and narrative. Start with the aims and hypotheses, describe the methods, present the findings, then discuss the implications of the findings. Minimize the use of acronyms and avoid jargon that only you can understand, and try to make the work so that it is understandable to any general reader or general medical reader. Consider the conceptual advance. So how does your work compare with previous literature, or why or how is your study unique? And also, what is the clinical or public health relevance and the potential impact of your work? And discuss that as well. So just throughout, I guess, as a summary, really, and what you can do to strengthen your study design and when you're writing a manuscript or before you start the study, just throughout the whole research process, what you can do. So stay up to date with the latest information in public health and clinical research. Some leading journals are fully open access, where you can access them. Browse the ICMJE recommendations on best clinical research practices. So Nature Medicine follows the ICMJE recommendations, and all the things that I was discussing about reporting, registration, these are all, you can find them all in the ICMJE recommendations. Support open science initiatives like data deposition, making the data publicly available, and making the your study protocol publicly available. And also engage in the peer review process. So peer review process as a reviewer is a way in which you can be involved in assessing the rigor and improving the quality of the manuscript. We particularly look for a local perspective, whether the study is local, relevant to local context, and your expertise is essential. So what else can you do? So seek training and resources like workshops and online courses on research methodology and statistical analyses. Build collaborations with researchers from other regions, but make sure that you are involved in every step of the process. Make sure that you hold them accountable, and also making sure that you are working in an equitable partnership, that they are not exploiting your expertise and resources to advance their career. Avoid predatory journals. Predatory journals promise rapid publications. They have no clear policies on retractions or corrections. There's no description of manuscript handling processes. They are not indexed of, but these papers published from predatory journals are not indexed by databases. So there's no little value of predatory journals. And so I put a guide to spotting predatory journals here, and I think you should check it out. And it is publicly available, this guide. So please look at that. So thank you very much. And yeah, it's really a pleasure. And please, if you have any questions, I will be happy to answer. Thank you.
Thank you. Thank you so much, Dr. Ming. Thank you for this amazing overview. And I hope this will guide a lot of audience here to submit more and hopefully get published in Nature and Nature Medicine, inshallah. So we have a few questions. Okay. So a lot of thank yous. There's a lot of excellent interaction from the audience. But does anybody have any questions for Dr. Ming?
I'm seeing a couple of hands up, I think. There is...
Yeah, please go ahead.
Hello, thank you so much for this excellent presentation. My question for you is this. I know it's going to be like a very, I guess from a perspective of like the COVID pandemic and what happened with censoring of a lot of publications and the like the impact that it had on so many countries globally, and the chaos and the collapse of certain countries' economies, and the refusal of basically great articles that were showing promising effects of certain medications on the disease process, the COVID disease process, and all that. How? What are you guys doing now to prevent something like that from happening again?
Wow, that's a really good question, because for us, we're kind of moving, in some ways, moving away from the COVID, you know, in terms of the retrospective aspects of the COVID pandemic. But what we're interested in are really I mean, first of all, we are, what we are trying to do is really to look at how can we prevent the next pandemic. So, what are the sort of health systems research that looks into ways in which you can prevent the stresses of the effects of the disruptions to healthcare systems from different countries and not just the high income countries, but also from low resource settings, as well as not just we have to really move away from not just talking about the COVID pandemic, but actually for a future pandemic X or future epidemic X. Especially looking into like surveillance, looking into infectious disease pathogens that could potentially become that can potentially spread. And for example, looking at zoonotic diseases and sort of outbreaks in other regions, and looking into the ways you can have early detection, fast detection, and ways in which one can potentially develop a vaccine in the future. Yes, this is, of course, this is all very, very speculative, but I think, it's really looking at what to do to prevent the next infectious disease outbreak that can have pandemic potential. In terms of the treatments and I think it's quite tricky because with the COVID, well, I guess, I mean it's.
I think we need more transparency. I think we need more transparency to prevent another pandemic, or to really a global pandemic. In that, I think we have to be more honest in the way that things happened, and basically really truly address the aspect where politics and certain pharmaceutical companies' greed and let's just say that we really need to have more transparency and honesty, so that with the prevention of another global pandemic, all these issues has to be addressed and known globally, so that we also prevent unfortunate deaths, and also there were very much easier ways of dealing with the pandemic, but unfortunately it seems that there was a lot of censorship.
Yes, fundamentally, I think the one key thing that the pandemic has highlighted is the global inequity in the way the response had been handled. The fact that the vaccines have been rolled out very, very fast and completely accessible in high-income countries, and there was just no or very little consideration into the low resource settings, and how it was so difficult to have roll out in low and middle income countries. And it's really, I personally, I don't have a single answer for how to make this equitable, but it is essential that I think at least as a journal, we need to champion local perspectives and local research, and really be involved in the capacity building, so that people can have their own interventions and have their own ways of dealing with the local issues. And I think in that way would reduce the global disparity gap. And I think that
Yes, and actually that was prevented, unfortunately. Certain countries, definitely in Africa and other countries, they were having promising, with certain treatments, drugs, they were having promising outcomes, but then they were shut off, and they had to use methods that were actually not working and made things work. That's why I'm saying that we have to be very transparent and in the journals, and very transparent in how do we transmit information, and let it be much more as I said, transparent and honest, and not to have anything to do with, unfortunately, politics and money.
Thank you.
Thank you. Thanks so much, Dr. Alia. We take now the next question. There's
Just
a question about the barriers to research in terms of publication fees in low and low middle income countries like Jordan,
Yeah.
or student researches. So is there like a fee for low middle income countries?
So we, at least for Nature Medicine, we have recently introduced I think it's a waiver policy for low and middle income countries. So based on the, I guess, the definition of low income country from the World Bank. So and I guess I'm meaning it is the article processing charges. So yeah, so I think it's at the moment it's only a few, like 20 something. Is it 20? I mean, I think it's 20 something countries, which personally I don't think it's enough, but yeah, I think it's certainly a challenge, and this is not just the thing about Nature Medicine or Nature as well. It's across many journals, including the Lancet journals, even many open access journals. And yes, it does exacerbate inequities in terms of the publishing process. But I guess for the Nature journals as well, it is also a hybrid publishing system. So you can opt to have a subscription, I guess go to a subscription route where it is not publicly available, and there's a need to be institutional subscription to look at it, but to look at the paper. But that is also not ideal at all as well. And so yes, I mean, I have worked with many researchers and authors in Brazil and other Latin American countries, and they do not have the means to provide fees for that. And unfortunately, there is certainly this is inequitable, and it is going to be a challenge for publishers and editorial journals to solve. And yeah.
Okay, thank you so much. Thank you so much. We're going to wrap up the question session now because it is time for our next speaker. However, I will email you, Dr. Ming, the remainder of the questions. We have something about the time duration from the conduct of a study, which is like 5 years. Can this be published? That is a question. But I can email you a few of the questions and we can email them back to participants. So thank you so much, Dr. Ming.
Thank you so much.
Thank
it's
you,
my pleasure.
and have a safe trip and hope to see you soon.
Thank you very much, Laila. Thanks. So hope to see you sometime this year. Thank you.
It was wonderful to see you. Yeah.
Thank you so much, Will. Thank you. See you in 2 months or one and a half months. So thank you.
See you soon. Yes.
Thank you.
Yes. Travel
safe.
Take
care and God bless.
God bless. All right. Am I up, Laila?
Yes, we will present our next speaker. Dr. Will Ngwa will now present our next speaker, Dr. Lydia Asana. So go ahead, Will.
Yes, so sure. So this lecture is going to be about qualitative methods in research. And I'm so excited to be able to present today. I'm honored to present today our next speaker who is going to talk about this, who is a bigger expert on this than I am. So I requested that she help to do that. So Dr. Lydia Asana is actually a director of our Young Global Health Catalyst program. So she has been doing these things at Harvard, and since we moved the GHC to Johns Hopkins. And she's also a professor at the University of South Florida in the United States. So she did a PhD around qualitative research methods. So I think she's probably the best person to give a talk on this. So I'm going to hand over to her, Dr. Asana.
Welcome, Dr. Lydia. Thank you so much.
I'm so happy to be with you all. Can everyone hear me?
Yes.
Super. Want to be able to share, and of course,
You should have the permission.
I do. And then I have a new laptop, so it's telling me all different kinds of things. But I've also emailed it to you, Victoria. Could you check what I emailed to you? Because somehow I'm not.
I have not received an email from you yet.
Okay.
It
Will?
might be taking its time if it's a large file.
It's traveling all the way from. All right, 1 second.
And while she's trying to set up, I think it's a good time for to just make a plug-in here about, we think that we have these the upcoming Global Health Catalyst Summit that Dr. Yang mentioned, Laila. I think with the wonderful participations we have today, we're actually going to have an online option that I think we can share with all the participants. There's going to be a lot of, we're going to have the editors of the Lancet, of this Nature Medicine, and they're going to be doing a workshop. It's not really a workshop, but some lectures with the young catalyst working with Dr. Asana. And I think it will be a great opportunity, for everybody who wants to participate to also participate. So we're going to send information about that, about that opportunity after this workshop.
Thanks, Will, for sharing that information. Will, could you please check your email? Because I think the settings on my new device are limiting my sharing abilities right now. Not so fun.
I think it would be a fantastic opportunity to streamline the proceedings of the Global Health Catalyst Summit this year. Inshallah, it will be on the 7th of June, the opening session for 3 days. And there will be a participation from Jordan, and there will be recognition of all participants in this workshop. So great. So I see the PowerPoint is on.
Right. Thank you, Will. And I apologize for that delay. So
when you want me to long, just let me know.
ooh, I get to have him work for me today, Victoria. I should make the most of that. All right. So yes, so pleased to be with all of you today. As mentioned, my name is Dr. Lydia Asana, and I'm here to share with you about qualitative research methods. And I'm hoping that it will be an interactive session and that you will make the most of the chat feature. My focus really today is to emphasize the need for meticulous methods so that we have credible conclusions. Because I think the landscape is changing, but for many years, there was some question about the credibility of qualitative research methods. But this is something that is necessary not only in social science research, but also in a lot of the medical types of research that many of you would be interested in. Sometimes we just need a yes or no answer or those numbers to calculate, but sometimes we want to understand the context in which things are happening. Sometimes you want to look at, for example, how well your patients are adhering to your instructions, and maybe the context is limiting their ability to take their medications at the prescribed time. Or maybe you are needing a patient to spend more time outdoors just for their physical health, and you find that without understanding their lifestyle, you really can't address the challenges that they're having. So qualitative research gives us an opportunity to look at a more holistic picture when we want to answer certain questions. So that's what we'll be doing today. Will? All right, so first of all, Will has mentioned who I am a little bit. One of the things that's important with qualitative research is that the researcher is actually involved in the research, unlike quantitative, where we tend to try to maintain that independence. And so as a qualitative researcher, you need to be able to introduce yourself and talk about yourself and find potential points of interaction, potential points of conflict, so you can identify those. So you always need to be able to introduce yourselves, not just in the professional sense. And so I'll model some of that in the way that I introduce myself. So in terms of this context, I would say I'm a global health catalyst, and that's why I'm here with you today. And as Will mentioned, focused on young catalyst engagement. And young catalysts for us, we start from high schoolers, but all the way to those who are medical students, residents, and beyond, who we call our emerging young catalysts who are getting ready to enter the workforce. And I also teach global health courses at the University of South Florida. My background, I've always enjoyed biology, always enjoyed things related to health. And so my undergraduate studies were in biology. And then I realized that I cared about why people were ill and maybe what we could do to help them not be ill and health education sorts of things. And so I've always been involved in volunteering and going to communities and working. And I thought, well, maybe I should get some formal training in nonprofit management so that we can do this correctly, the work that we do, the philanthropy work that we do, hence the master's in nonprofit management. And then I realized that really for these types of efforts to be sustainable, policymakers need to be involved, and we need to be at the table where policies are discussed. So hence my doctorate in public policy with a focus in international nonprofit organizations. But as is true for all of us, I have many roles, and my existence is not only focused on work and learning. I am a wife and a mother, a daughter and a sister, a friend and a teacher. So not just the faculty work, but also teaching our children and different roles in the community. I think it's very important as part of my identity. I am a member of the African diaspora. I was born in Cameroon. I am joining you today from Orlando, Florida, in the United States. And my favorite fruits are mangoes and watermelons. Will? Next, please. Yes. And so, in order to be involved, in qualitative research, like I said, we do need to get involved and get to know our participants. And so here is where you will start by please putting in the chat where you are joining from and what is your favorite fruit. So let's see if there are any others who are mango lovers, watermelon lovers, or maybe you'll introduce me to some fruits that I don't yet know. The fig from Jordan, figs in Jordan, watermelon, okay. And I'm still planning my trip to Jordan, so I guess I'll be prepared to have some figs. Apples, I see. Grapes, joining from Cameroon. Simon Pierre, your favorite fruit? Strawberries, lemons, pineapple, berries, pineapples, yes, my son's favorite as well. Mangoes, my husband's favorite. Tomatoes, lots of pineapples, strawberries, blueberries, bananas, yes. Dragon fruit, good, something new. Raspberries, strawberries, lots of berries, which is a great thing. Mangoes, all right. Fourth, oranges, Cameroon. Good, good, good. So thank you, first of all, for your participation. I'm seeing lots from Cameroon, from Jordan, lots of berries and strawberry, watermelons and so forth. And so it's really important when we're involved in qualitative research to find the connections that we have with our target population. And we'll talk a little bit more about that when we talk about who is involved in this type of research. So thanks for your participation and stay alert. Those of you who are half here and half cooking and half writing a term paper, I hope that you'll participate in, we have a few more questions and ways to engage coming up. So yeah, so the goals for this particular session, our goal is to, well, my goal, and I hope that we will succeed in this, and at the end, we will be able to assess, and so that'll be a test on me, not really a test on you, how well I've been able to communicate this information. And so my goal is to educate you on what qualitative research is. Some of you may be aware, some of you may have heard of it, some of you may already be involved, and I would encourage you to chime in and you know, feel free to add, to edit, or inform me if something has changed in recent days, because that does happen. And then my hope also is to equip you with some best practices. So we will have some opportunities for you to test out what you've learned, or to think through the process, and maybe even try out crafting a qualitative study question and the types of things you need to keep in mind. And then, of course, engagement, not only in this particular session, but also to see beyond this session. I hope that you will think about learning more. There's only so much we can do in the hour or so that we have. You would consider joining a team that is involved in qualitative research. Perhaps you would consider designing a qualitative study or participating in a qualitative study. I know that you just had a speaker talking to you about publications and the great opportunities that are there. But sometimes there is a shortage of qualitative perspectives when it comes to the medical field. And so I think there's room there for us to add more qualitative studies, and also to partner and possibly do mixed method studies where you partner with a quantitative team and you bring a qualitative perspective. Next, please. Next slide, please. All right, so there'll be 3 different aspects of our talk today. Part of it will really be like a lecture. So there are some notes with a few bullet points, and there are some slides that are more blank that I would like to encourage you to, you know, take some notes for yourself. And this is my way of trying to encourage you to stay connected and alert. And then we'll have some practice where, again, we'll have some questions, some opportunities to give some responses and try some things out. And then our traditional question and answer towards the end. Next slide, please. All right, so we're going to look at a few or 6 different ways of looking at qualitative research: what it is, why it's relevant, when it's recommended, who is involved, how it is conducted, and where to share. Next, please. So first of all, what is qualitative research? The first thing, of course, to think about is, what is research? Qualitative research sometimes is dismissed as, you know, people just asking questions out of curiosity because, you know, they want to know, they're just curious. But curiosity is at the center of all research. All research that is conducted, somebody starts out with a question or an observation of a problem, a situation that you would like to either better comprehend or provide an intervention, hopefully to make the situation better. So just like any other form of research, whether it's bench research in the lab, or it's, you know, meta research where you're collecting a lot of data and creating a lot of numbers, typically for quantitative, but in this case, we would be doing lots of words for qualitative. But we start with an observation of a problem, a situation, something that we're curious about, or something that we hope to be part of a solution for. And then, like every other form of research, there are methods and processes that we need to follow in order for it to qualify as research. And like any other form of research, there is data that needs to be collected. It looks a little bit different, but when done correctly, it is still credible data. And then we have results that we need to be able to analyze and publish. When we hear the term qualitative, what should come to mind is that it is descriptive in nature. Often we are comparing responses from multiple respondents in order to describe a situation, as opposed to just summarizing with what is the average based on the numbers collected. I see Nelly has a question. Can we say that most of quantitative research have a qualitative part? Quantitative research can have a qualitative part, but when someone is doing strictly quantitative research, they kind of have blinders on to focus on the numbers, to focus on the statistics that are numeric in nature. But oftentimes when you analyze quantitative data and you come up with results, there's often a question of why. Why was this the norm? Why was this the median? Why was this the outlier? And so that's where a qualitative part can come in to answer that why. So strictly speaking, quantitative research will stick to the numbers and the averages and so on, but there is the potential to build on that with qualitative afterwards. And sometimes the reverse is possible. So there's the potential, Nelly, for a qualitative portion, but there you would then have a mixed study if you wanted to do the both on the same study. So thanks for your question. Next slide, please. So let's compare a little bit quantitative versus qualitative methods of study. In quantitative research, we're often seeking to confirm a hypothesis. So we have an educated guess, we have some context, some background for which we have created this hypothesis. And then we conduct quantitative research in an effort to confirm that hypothesis. However, for qualitative research, we're exploring ideas. We're curious, we've maybe observed something that we're not sure, is it really a thing? Is it a trend? Is it an outlier? Let's explore to see whether this actually is something that can be termed a hypothesis. In quantitative research, it's very structured. You have to have specific wording so that you get the specific responses, either one-word answers or specific numbers that can be analyzed using quantitative methods. In qualitative research, it would be very limiting if your questions are very structured. So we talk of semi-structured questions. This does not mean that it's random, that it's not thought through, that it hasn't gone through vigorous writing and rewriting to make sure that the question will solicit the answers, the types of answers you're looking for. But it is not so fixed that this is the only way you can pose it, because a lot of times we are observing organic context, and we're observing or interacting with people who differ. And so you can't expect to use the exact same words, and actually we don't expect the exact same answers. We expect a range of answers from which we will then analyze to find conclusions. Quantitative research is highly inductive. So we make observations from the research that we conduct, we can now make generalizations from that. Because I was able to switch the light off and on several times and watch the bulb go on and off, and however many times I do that, I can generalize that every time I switch on the switch on the wall, the light will go on. However, in qualitative research, we're using deductive forms of reasoning. So we have a general idea that children like sweets, but why do they like sweets, or how are they introduced to sweets? Do they like the same type of sweets? Is it the same type of sweets in every culture? These then become things that we want to draw some kind of conclusion related to the general idea that children like sweets. But we want to answer the whys and the hows and the wheres And so we need to add, we start with something general, and then we look for some specificity in our conclusions. In quantitative research, we have a controlled context. And in fact, we always talk about having a control experiment to compare it to and to make sure that we have not strayed too much from what we said we were going to do. In qualitative research, we value the organic nature of the context. So for example, if you were observing children at play and your goal is to make observations on how children play or how they make use of what's around them, we're not going to put them all in the exact same room with one toy and just see what happens. I mean, you could do a quantitative study and measure how many times the child picked up the ball, for example. But in a qualitative study, we would want to watch these children in a playground and see what they do with what's there, watching them in their organic context and considering what is in that context. We would observe and describe what that playground was like, maybe what the weather was like that day, because we understand the context may influence the data that we're collecting, and that's okay, and it's actually very important for the results that we have. So we want an organic context, and then we take into consideration not only the questions we've prepared or the points that we've jotted that we want to observe, but also what is happening around so that we can have a holistic approach. Quantitative questions are typically closed-ended. Are you hungry? Yes, no. I mean, you know, my kids will say, well, you know, maybe I am, until they know what's for dinner, and then they've decided that they're not so hungry anymore if it's not their favorite. But then that wouldn't really, you know, we typically get a yes or a no answer for are you hungry? How many times did you eat today? I ate 3 times today, a very specific closed-ended question with a very specific answer. But for qualitative research, our questions are open-ended because we don't want to miss collecting something relevant just because we narrowed down the options to a yes or no for our participant. In quantitative research, the researcher is independent of what they're observing. So our goal is to be unbiased, objective, and in quantitative research, that means I am removed from the research. I'm observing, I'm collecting data, but I am not influencing the context, and I'm not influenced by it besides just, you know, collecting what I observe. But in qualitative research, the researcher is involved. And so your role as the researcher is really important. You need to be properly trained because you will influence in some way the responses that you receive, but this is not necessarily a bad thing. Our goal is to steer along a particular path, but allowing our participants to walk either on the right or the left of that path, but we are going in a particular direction. So again, it's semi-structured, where we know generally where we might want to go, but we need to allow our participants to lead us in a sense so that we can get the types of responses that we're looking for. Next slide, please. So why is qualitative research relevant? And so this slide is a bit blank, but I would like you to think about that. Some of the things we've talked about, the differences between quantitative and qualitative. Why would it be relevant to have a qualitative perspective? So already I've said qualitative types of research answer questions that we can't get from closed-ended questions or bring us solutions that we can't get from closed-ended. It's relevant because sometimes we need an explanation, not just a number or not just a statistic. Sometimes we want to understand why something happened or how it happened, and not just when it happened or how often it happened. And so the relevance, particularly for a medical setting, I think more and more as we understand the importance of global health, the importance of the connection between local health and global health and the fluidity that exists there, we find that it is necessary for us to look at a holistic picture more and more. And so qualitative research gives us the opportunity to fill in some of the gaps that exist when we get quantitative research and we find a pattern, but we still don't know why, or we get quantitative results and we have some exceptions that we can't explain, and we want to understand those exceptions. Particularly in global health, those exceptions are often what are causing gaps, because if we ignore those exceptions, then we're ignoring subpopulations of the world or of a community, and then that increases the gap in terms of access to care. So the relevance of qualitative research, to me in particular, is to trying to fill the gaps so that we have a more holistic response or holistic understanding of any situation. Thereby, we can better provide holistic, sustainable solutions. So qualitative research answers some questions that quantitative cannot. I think the next one was, when is qualitative research recommended? Again, it could sometimes go before or after a quantitative. So you could, for example, conduct a quantitative study, come up with some statistics and a clear, majority that you can draw a conclusion from, but you don't understand why. So it's recommended when you're still left with questions after your quantitative. That would be a good time to say, well, maybe we need to add a qualitative approach. When you're still left with questions after your quantitative. Sometimes qualitative research is actually the gateway before we can collect quantitative research. If we're dealing with, for example, special populations or isolated populations that we do not yet fully understand, it may benefit us to first get to know the community, get to know the participants or the residents of this community. And a more natural way to do so would be to conduct some research related to your ultimate goal. If your ultimate goal is to learn, how they're using a particular medicinal plant, you may not immediately just go and start asking, well, how often do you take it? And, how many times a day do you take it? Do you, those types of things that will be very quantitative, but you may want to get to know the community and get to know the relationships within the community and how they value the plants and the crops around them, and having them show you and identify so you can recognize the pride they take in their medicinal plants, in their phytomedicines. And then from there, you gain some trust, you build some relationships, but you have a context from which you can say, now let's get some specifics. So sometimes qualitative research is a good gateway to collecting a lot of data for quantitative. So it can go either way, and it depends at what stage you are. Who is involved in qualitative research? So very similar to quantitative, you do need your target population or those you're observing. You do need the researchers, and typically a research team is still a good idea because we bring different strengths with us. You're going to have people who are very good at creating these open-ended questions and reviewing them for comprehension, for clarity, for effectiveness. You're going to need people who are very good at interacting with people. If it's an interview, for example, you're going to need people maybe who are the gatekeepers who will help you to solicit the participants that you need. You're going to need people who give you the credibility by approving that study. So those, your institution and maybe the IRB for your institution. You may need to have support letters from a community, from an institution before you start interviewing, for example. So there's a whole host of people involved. It's not just, well, I took up my pen and paper and I went to ask a few people a few questions. Again, because our goal is to have credible research, the methods and who is involved. You still need to be trained, you still need to be credible in how you do it, and you still need a number of people involved to help keep it objective, to keep it reliable, and so forth. So A host of people are involved, meaning that you can be involved at different levels as well. How is qualitative research conducted? So typically, again, we would start with that problem, something that we identified that needs to be taken care of. Can I see the next slide? I'm not sure if there are details in the next one. All right, so yeah, so the process and how that's conducted. There are problems that we first observe. And when we identify this problem, then we want to identify the population that needs to be involved in helping us answer the questions or solve that problem. So you need to identify the target population and define them in a way that all who are involved are adding value to your research. So whether you want to do one-on-one interviews, whether you want to do focus groups, whether you want to do case studies, you have to be able to describe a specific population that you are aiming to involve so that you have some context for the results that you have. Remembering that we're doing open-ended questions and we may get different types of responses, a way to provide some sort of control for our experiment or for our research is to ensure that we have a very defined population. A very defined population. And then before you even start coming up with questions, you do need to do your literature review, just like with any other good form of research. And I believe you will have a lecture on literature review coming up soon. And so you will put that piece to this process where you first do your background work. You had a question, you had a problem, you're thinking maybe I'd like to work with teenagers, maybe I'd like to work with this particular school district or this particular community. You need to first find out who's already studied this community, who's already asked these types of questions. What did they find? What were their challenges? What did they say potentially still needed to be done? So that before you embark on a study, you have some assurance that it's a study that is needed, that you are adding to the wealth of research knowledge that is out there in order for your study to have a greater impact. And so once you've done your literature review, you then need to come up with a theoretical concept. So unlike a quantitative study where we're going to have a hypothesis and then seek to see whether we were right or wrong, in qualitative research, we typically are looking at a concept, an idea, an understanding, and then we engage people in the community, or, you know, if you're doing it with people, you could observe also animals and things that are out there as long as it's descriptive, but you're starting with a theoretical concept. And some of this will be formed from what you find in your literature review. Some of it will be formed from what you find in your study of theories in that field, whether it's social research or child development or, you know, a number of fields. There are existing theories. And so having an understanding of these theories will allow you to formulate a concept that you would now want to pursue as your research goal. And then when the next thing you would do is there are a number of documents that you would need to collect, because before you actually go out and engage, especially human participants, you will need, you know, informed consent and IRB and all those critical things that make our work credible as researchers. And so you would want to find out what are the documents that you need. Again, if you're going to a community, you may need the principal of the school to give an approval that you would come in and interview their teachers or observe their classes. If you are working with, for example, for one of my studies, I worked with nonprofit organizations in the Florida area, but I needed a letter from a member of the leadership team of these nonprofit organizations that they accept that I will interview members of their organization. So I needed to collect these letters and use that as part of my IRB submission, that I've done some background work, I've identified a problem, I have a concept in mind. I have people who are willing to work with me, from whom I can work with to get study participants. And so now I'm seeking the approval of a governing board, either at my institution or the organization, whoever I will provide that IRB approval. Now, when we need to get the IRB approval before we can even engage anybody and start asking any questions of anyone. And part of that IRB approval, very important, is of course informed consent, that everyone who's participating knows why you're doing the study, what will happen to the information, and how you will involve them in the end. So once you get your IRB approval, you can conduct, you can conduct a pilot study. This is sometimes helpful in quantitative studies, but in qualitative studies, a pilot study is really, really important because, Sharuk, in a minute, I'll look at your question. I do see it. Because the pilot study can help you to reformat your questions or rephrase your questions. So it's important to remember that what the IRB approves is not set in stone in terms of the questions that you will ask. And for a qualitative study, the IRB is aware of that, but you do need to propose, your semi-structured questions. This is the direction I'm going, and this is, generally what I will be asking. But until you test out those questions, you don't know if you will be understood, if you'll actually solicit the types of responses that you need. And so a pilot study is really helpful to engage a few people from your target population with the semi-structured questions that you've prepared and collect data and see whether you are getting answers that make sense or that are correlated in some way. And if not, you may have to go back and rephrase your questions before you come up with your final set of questions. I think this sometimes is surprising to people that IRB has approved it, and then I went and I changed my questions. But in the qualitative realm, that need to adapt a little bit. You need to do that in order to actually succeed. So let me see, I see a question. Are the participants' narratives of conditions they experienced from before considered a reliable source for a qualitative research? I'm not sure what you mean by from before, just their past experiences. But yes, what your participants provide is they are a reliable source, because what you're aiming to understand, they have experienced. So in this case, what they provide, whether or not it's surprising to you, it is their reality. And your goal as a researcher is to analyze their reality and then come up with results based on what you were able to collect. So yes, we're not saying, the participants, their experience makes them experts in a sense, because it is their experience. And as long as it's relative to the information you're trying to collect, then yes, it is reliable. Now, there are still things we need to do to make the information credible. And a lot of that depends on the process and following this process properly. But a lot of it also depends on you, the researcher, and how you're conducting the study, how you're asking the questions, how you're coding the questions, how you're analyzing the questions, so that you are seen as credible. And we're going to look at some vocabulary words in a little bit that you want to make sure that you accomplish. But the short answer is yes, your participants, their experiences are reliable because you're trying to make sense of their experience. Okay, thanks a lot. I meant medical history of a patient, but from the participant narrative to ensure their privacy. So yes, there are things that we do to ensure privacy, and one of those is coding that we'll talk about in a little bit, because it's really important, yes, that we make sure, whether it's medical or not, sometimes with qualitative research, there is sensitive information that we need to code. But in terms of medical history, the coding will be important. The way that the researcher poses and notes and stores the information. All of those things will make it reliable at the end of the day. Again, you're getting it from their perspective. You're getting it from their perspective, and so that makes them a reliable source. Does that help? Sure. Okay, great, thanks. All right, so let's look at some of these terms. I've mentioned some of them already. The things that would make your research credible. Again, that is very important that you're viewed as a credible researcher. One second. So how you go through that process, again, honoring IRB, making sure you have informed consent, making sure that your questions are legitimate, they're understandable, you can repeat them, and so on. But there's this element of coding, which I alluded to a little bit ago. We have to find a way that if somebody were to pick up your notes, they wouldn't be able to tie the responses to a particular participant. You also want to code your work so that when you're analyzing, you're limiting the biases. You're not able to easily say, oh, this was Susie who I grew up with, so yeah, she doesn't know what she's talking about. And so there are ways in which we identify our participants without making it obvious, so that when we're analyzing, we're working in this world of codes, and then afterwards we can decode, or someone else can decode for analysis and dissemination. And then the other, really, again, I've said this a few times, but in qualitative research, this is really important, the credibility of the researcher, because you have the power to modify the questions. You have the power to take note of certain things as you're asking questions. Again, if it's an interview, if it's a focus study, if it's a case study, you're making observations even when you're asking questions. And so as if I'm interviewing someone, I'm taking note of what they're saying. Oftentimes I would ask permission to record them orally so that I can play it back and I didn't miss anything. But I'm also observing their facial expressions. Did they suddenly withdraw? Did they suddenly look really excited talking about their pet? Did they suddenly look really hungry talking about watermelon? But those kinds of observations provide that context that we've already talked about that plays a part in saying, this is what I observed, this is what they said. And at the end of the day, we're putting all these things together when we are coming up with our conclusions. Given that the clinical trial aim is to generalize findings, can it contain qualitative method, a clinical trial? So in a clinical trial, I mean, the different phases of a clinical trial have very specific objectives. And so if your goal is principally a clinical trial, it's typically to see how effective an intervention is, right? And so the different levels, trial 1, trial 2, trial 3 approvals that you're seeking through clinical trials will have very specific objectives, and that's your goal. And so I would say when you're doing a clinical trial, your focus is getting the approvals you need so that that intervention can actually be made available to the public, because that's your primary goal. I would finish that first before I look at qualitative elements. A qualitative element may come into play when you're looking at something like, whether or not you need to change the flavor of the medicine for the babies, right? But that would happen after you've already gotten approval to use the actual drug. And so I think when it comes to clinical trial, focus on the goal of getting those approvals. And then based on observations of your first few, your first few patients that you're approved to use, you can now do a qualitative aspect where you're asking, how did it taste? Describe, how it tasted and get their recommendations. Because the goal of clinical trial is very specific. I would not want to water it down by trying to add a qualitative aspect to it. Once you get your approvals, then yes, by all means, consider qualitative methods so that you have better buy-in, more people using the drug or the intervention for the outcomes that you envisioned. Does that help? Simone Pierre? All right, so transferability. When it comes to qualitative studies, we have to be cautious about saying, because this was true here, it's got to be true for everyone. We always have to be very particular about the population. Okay, Simone, I'm glad. The population that we involved in our study, and say that our results are based on this population. And so we could project conclusions to other members of that community, maybe, and other communities with very similar characteristics. But even as I say this, I'm cautious because from my house to my neighbor's house, we live in the same neighborhood, but the context of our families are still very different. And so I wouldn't presume that what everybody in my family has decided is the best way to prepare eggs is the best way that we should prepare eggs in my neighbor's house. So when it comes to transferability of conclusions and recommendations, we have to be cautious and put some very specific conditions when we make recommendations based on our qualitative research. So that's what I would really like you to remember. Just be cautious about transferring what you've learned. It's still meaningful, it's still helpful, but we can't just make blanket statements about all children liking yellow balls because the children in my household like yellow balls. Trustworthiness. So when we talk about credibility and whether or not we can trust the results, with quantitative studies, the numbers speak for themselves, right? And that's something that we can always say, just look at the numbers. They speak for themselves. We've got 90% compliance. We've got 30%, non-compliant, 90 and 30, that doesn't work, 30% of something else. The numbers speak for themselves. And based on those percentages, on those numbers, on those averages, we can make decisions, right? We can decide whether or not to invest. We can decide whether or not to buy more of this medication and so on. But when it comes to qualitative research, we gain trustworthiness through a process called triangulation. And so when you think of a triangle, you've got these 3 points connected with very specific lines. And so to triangulate your results, you could do it in a number of ways. But the goal is not necessarily replication, but you want to see correlation from more than one source. So you can achieve triangulation, for example, by we may have a team of multiple researchers that are conducting the research. And so if 3, 4, 5 of us, it really doesn't have to be just 3, even though it says triangulation. If 5 of us go to a particular elementary school to conduct an observation of how teachers teach math, we've agreed on the semi-structured questions we're going to ask, knowing that we may need to modify them slightly to make sure our participant understands and responds. The 5 of us come back with our responses, everything's coded, we're analyzing. There should be some similarity, we should be able to identify that, yes, we were actually working on the same project. And so there are trends, there are keywords that might come up that we can say, oh yes, the word behavior came up a number of times. So this is important in this setting. The word creative came up a number of times. The word attention came up a number of times. And so we are finding conclusions that we can rely on, that are trustworthy, because even though there were 5 of us in this one school, we have results that are showing some kind of correlation. So I can trust this research because it's sort of replicated. I'm not expecting it to be exactly the same, but it's correlated even though I had multiple researchers. So that's one way that you can go about triangulation. Another way that you can do it is through having multiple data sources. So even if I was the only one conducting that research, I could decide to go to multiple schools and not just the one school. So if I've asked the same types of questions of teachers in school A, B, C, and D, and again, I'm finding those same keywords, attention, creativity, then I'm seeing some type of correlation. I was still the only researcher, but I did this in multiple schools, and I'm finding some kind of, again, not replication, not identical answers, but I find keywords that could mean a number of things. The word creative could mean that the children came up with their own song, they came up with their own dance, they came up with their own design, but these are all different ways that they were creative. And so that's another way that triangulation can happen. Sometimes triangulation is getting these keywords, and then looking at other research that has already happened so that I can compare and contrast what others have found who conducted similar research. And so again, my goal is to make it very clear to anyone who is reading my research, who is interested in applying my research in their own work in some way, that they're able to say, this was not just, you know, Dr. Lydia's idea that she dreamt up and she called a few of her friends and they agreed to do this, and so it worked. So it's very key in qualitative research to earn trust through triangulation, having multiple sources that are correlating the key terms that we're coming up with that are leading to our conclusions. Then in qualitative research, we also, the word saturation is something that we are very excited about when it happens, because, you know, actually I had younger students today. I teach science to some middle school and high school students, and we talked about solvents and solutions solvents and solutes making a solution, and, you know, the salt in the water, and at some point you will see that your solution is saturated because you can now see the salt crystals, right? And so in qualitative research, one of the questions is, when do I stop asking these questions? When do I know that I've collected enough information, right? You don't want to stop prematurely and then miss something unique from participant number 15 because you decided 14 is where I'm stopping. So with qualitative research, you have an estimate of how many participants you'd love. You have a minimum. You strive for a minimum, but your goal is to keep going with as many as you can until you reach the point of saturation. And that means you're not seeing any new keywords coming out. You're not seeing any new key themes coming out. Because when we go out to collect data, again, we've decided that, you know, we're looking for certain themes. We're looking for wellness. We're looking for rest. We're looking for relationship. Anything that's related to that, you as the researcher would have to say, this, and this all typically mean rest. This, and this all typically mean joy, right? So all these different synonyms. But every time you interview someone, you often will come up with something else, and you thought, oh, well, that's new. I wonder who else will come up with that. So saturation is the point at which you're confident that there's nothing much new you're finding. And when you get to that point, you have reached a point of saturation. This is possible because, again, you have a very defined population that you're working with. And so at some point, their ideas, their beliefs, their experiences will paint a picture that can't fit any more shapes or colors in that picture. So that is the point at which a qualitative researcher can say, you know what, I think we're done. We can now move on to analysis. So saturation is a big deal in qualitative research, and sometimes it takes a while to get there, but that's one of the ways that we also say, you know what, we did our job well, because after this point, we really weren't hearing anything new. And then, of course, like all forms of research, you've got to analyze the data that you collected. and you can analyze the data manually, or you can use computer-assisted methods to analyze your data. But typically, whatever method you choose to use, you are identifying themes and keywords, and how many times you heard the word beautiful, 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 hurtful, 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 or a synonym of those, right? And so if you're doing this manually, you may need to dedicate a whole room and get out all the different colored markers and different colored Post-it notes, because you're trying to put things in categories that are emerging as you look at your data. I'm looking at I'm playing back a recording from participant A and from participant B and C. And this one said child, this one said kid, this one said minor. They're all talking about children. And so now I'm going to have a category on children. What did they say about children? And I might find that under children, there were very positive types of descriptive words. And so at the end of the day, in this culture, children are viewed positively, and use some of those examples. But that is one theme, a key word, and then the characteristics that came under that. And then I'm reading through, and I see the word family, and I see cousins, and I see relatives, and I see, different words that would mean family. And so that now is another theme that is coming up. I need to be able to identify that these are all talking about close relationships, familial relationships. And then I'm looking for, what are they saying about family? Is it bringing them joy? Is it bringing them stress? Is it bringing them memories? Whatever it is. But then those are the kinds of the keywords that I would put under that theme of family or relationships. And that's how we go about analyzing qualitative research. Doing it manually as a team and dividing things up, it'll still take a while, but it's worth it. Doing it, there are programs that you can learn to use that'll quickly find those keywords for you. So here's a question for you. I've put 4 different activities that may be part of the way that we carry out the process. And I would like you to see what you remember about the process. What comes first, second, third, fourth? Do you finalize your interview questions? Ahmed, I see your question. Just a minute, please. At what point do you get IRB approval, letters of support, pilot study? So I'd like you to see for yourself. I'll answer the order in a bit, but please see if you remember the order in which these activities happen. So there's a question here. Is there a way to prove saturation through a formula or something? So then in a mixed method study in partnership with a quantitative researcher is one way to do that. But really, the point of saturation, again, is when I'm not seeing anything new. So you could come up with a formula that says, in a 5-hour interview, the word thankful came up less than 50% of the time, less than 1%. Therefore, I've reached saturation. That's feasible, that you could say, hey, if I interview the next batch of 20 people and there's nothing new, the amount of information I receive new is less than 5%, then I've reached the point of saturation. You could, and then you would want to make sure that you share that information in your results, that you determine that saturation occurred because less than 5% of the information you were receiving was new, right? And then let your readers be the judge whether that was really enough. But it can give you, it can guide you, because really sometimes it's hard to know when to stop. I think the question would be, what percentage would be satisfactory, which brings us back to the question of how much is enough. But that's a discussion you could have with your research team and say, hey, let's do interviews in chunks of 10 people or chunks of 20 people. So if we've done 20 people and we see that more than 5% of the responses were different, we'll do another set of 20 people until we reach, new words are less than 2% of what we're looking for. I can see that as feasible. I would find that acceptable. Just be sure to include that in your research findings and methodology. Yeah, but I think most of us, we just keep going until we feel like I've not heard anything new. And then we go back and review what's there to be sure. Does that help, Ahmad? I think that's actually a pretty good idea. You just as a team would need to agree on what you think is a percentage that would be acceptable. All right, so while I was answering Ahmad's question, let's see, you tell me in the chat, what comes first? Your final interview questions? Let's see, we have, yep, go ahead and put. So there's 1, 2, 3, 4. What's the order in which these things should happen? I see 1 in the chat. Let's go. You all can do that. So what do we do first of these 4 things in the process? Not necessarily the very first thing, but these are 4 things within the process that happens. And we wanted to try to put these in order. Let's see, 1, 2, 3, 4. I see 1 answer in the chat. Any others want to try? Let's see, Mariella. I think your name is beautiful. I'm trying to pronounce it. But Danya 2241. So we need at least an odd number, at least a tiebreaker. Let's have at least 1 more in the chat because their thoughts are aligned. Can we have at least 1 more in the chat? Well, I agree with you. If these were the 4 things that I was trying to put in order, I would need to make sure I collect my letters of support because the IRB would want to see that. I would gain my IRB approval because that is necessary before I engage anybody in the study. And my IRB application would include that I intend to do a pilot study. So then I would do my pilot study, and based on how the responses that were received, I would then know if I need to modify my questions before I come up with my final interview question. So thank you for participating in that. And I'm thinking through some of the things that we talked about earlier. Yes, Wesam, 3241, 3241, yes, yes. All right, next slide, please. All right, let's talk about qualitative questions. Do you eat breakfast every day? Is that a good qualitative question? So this is a quick yes or no. Do you eat breakfast every day? 2 people so far say no. No, 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 no. Good. It's not a good qualitative question because the answer is a yes or a no if it starts with do you. And so for quantitative reasons, you can just collect how many people said yes, how many people said no, and you've got some numeric data. But for qualitative research, that really doesn't help us. If you wanted to do a study on maybe the nutrition of a community or cultural norms of a particular community, you want to ask a question about breakfast. What could you possibly ask? Let's see some suggestions in the chat. What do you have for breakfast? Okay. So you could ask what, so people are forced, well, they're encouraged to answer. Yeah, so what do you have for breakfast? Eggs, pancakes, sausages. And then, well, in some countries, you know, my mother was here, and thank God for mothers and grandmothers because she was cooking a lot of Cameroonian food. And one of my sons enjoyed the fufu so much, he asked to have it for breakfast. So that would be an outlier in my family. It's not normal to eat fufu for breakfast, but you know, he enjoyed that. So what do you have for when do you have your breakfast? Yes, if you asked when, people would answer morning, afternoon, evening, or give you a specific time. And so again, when you ask the what and you ask the when, you would get some information, but could you then quantify that information easily, right? Could you say 50% of the people had breakfast by 9 a.m. and 40% of the people had breakfast at 10 a.m. and only 10% of the people actually had breakfast at 7, right? Or what do you have for breakfast? And then we have the list of things people could have, and then we could put those in categories as well. Is breakfast important to be taken every day? We could ask, but when I ask, is breakfast important? Would your answer be yes or no? And so then again, we've come to a dead end very quickly. So I appreciate your participation. Let's see some more ideas. How could you turn that around? Like the idea of importance, we could rephrase that and maybe say, tell me the role that breakfast plays in your day, right? So if I ask someone to tell me the role breakfast plays, they might say it plays no role because I don't take it. But some people may say it's really important because it keeps me going or it makes me awake, but you've allowed them an open-ended way to describe. Some people will always still just give you the short answer, but some people will be more descriptive. What do you think about the importance of having breakfast every day? Yeah, what do you think about that? Some people would say, no, it's not a big deal. Some people will say, yeah, it's the most important meal of the day, right? And so here's the thing that I did not really mention before, but this is the time to tell. How do you believe breakfast choices affect your mood and energy? Yes, somebody definitely has to explain when you ask how. Could you describe your breakfast habits and routines? So I think, and this is a good example again, I think I know what you mean and you're right. And this is where your team would come together and say, well, let's maybe reword that. Because if you say, could you describe? I could say, yes, I can describe, or no, I cannot. But if we said, describe your breakfast habits and routines, then I'm actually asking you to do the description. So your intent, I understand, is correct. I just wouldn't ask if they could or not, because some people would just say, yes, I can describe, or no, I can't. How often do you have breakfast and when do you have it? How often? 5 times a day, 10 times a day. I'm getting numbers that, again, I can quantify. When is also a time, but we could say, describe the setting at which you have breakfast. And then some people will go into, well, before the sun comes up, I'm setting the table. And, if some people just really go into their whole breakfast routine, then it tells us something about the importance they have or they attribute to breakfast, whether they have it alone, whether they have it as a family before everyone leaves, will give us some description of their context. So here is something that might help you and was left out on purpose, so you keep learning. When you design your open-ended question, it's okay, and actually you should have follow-up questions that you can ask, right? So is breakfast important to be taken every day? Somebody said maybe we ask why. Why is breakfast important? If you ask why is breakfast important, some people will say it's our tradition, it's our habit, we eat all together and that's why it's important. Some people will say I have a long day, so if I don't eat, and then you follow up. What makes it important for your family? So you should already have some follow-up questions, because sometimes somebody will give you an answer that is just so short. So if you ask, why is breakfast important? And they say, because it's the time we sit together. Then you can ask, what makes it special that you sit together? Well, we're all going in different directions and we really don't get to be together again. By the time I get home, the kids are asleep or so on. And so then you ask, and so how does that make you feel when you eat all together? So you can have follow-up questions to your initial question. That is acceptable and actually encouraged that you already have them prepared. What healthy options do you include in your breakfast? Okay, so when we ask what healthy options, I can list things that I can group and then still put them on a graph or a chart. You can ask what makes your breakfast options healthy, and you could say it's because we use all natural ingredients, or it's because we make sure it has whole grains, or you think up some follow-up questions. What healthy options do you include in your breakfast? Why do you make those particular choices for your healthy breakfast? So a follow-up would be good for that one. Could you describe your breakfast habits? That would be a good one. Again, I wouldn't start with could, and I think that's more just a language thing. Just ask them, please describe your breakfast habits and routine, so that they actually do the task instead of wondering whether or not they want to do it or they could do it. How often do you have breakfast? So each case may have its own questions, is what Naja is asking. So again, remember you have the semi-structured questions. you should already prepare your question. So we had some good ones here, like, let's see. There were several good ones. How do you believe breakfast choices affect your mood and energy? How does breakfast affect your mood, right? So that could be my semi-structured question. And if somebody doesn't really get it, I would ask a follow-up question that is still related to my initial question. How does your choice of breakfast affect your mood and your energy? And somebody could say, oh, it really makes a big difference. And then I would follow up with, in what way does it make a difference? Does more breakfast give you more, not does, but in what way does it make a big difference? So your follow-up questions are not completely new for each person. You start with what you had agreed would be your semi-structured, but you might need follow-up questions to guide them to make sure they actually answered that first one. Okay, I think that was a question that Naja had. All right, so what do we have next? If your goal, all right, here's a good one. All right, follow-up questions, we just talked about those. For a different scenario, but we could go to the next slide. Because again, if you ask someone an open-ended question, tell me about your typical weekday, they could say a lot of things. But if you really wanted to hear about how much time they spend sleeping, you might have to follow up. All right, so here is a question. Remember I said it's the role of the researcher is really important in qualitative research. If you grew up in country A, and you moved away as an adult. So you lived there until you were in your late 20s and you moved away. 5 years later, you come back to conduct a qualitative study. Where should you disclose this information? So you lived somewhere, you moved away, and 5 years later, you're coming back to do a qualitative interview with some people there. Where should you share the fact that you grew up in that country? Is it A, don't tell anyone because you want to remain objective? Is it B, only in the introduction to participants because you want to establish a connection? Or is it C, disclose to all parties involved in the study to establish and uphold the credibility of your study? Let's see, A, B, or C, what do you think? I see lots of responses coming in. C, 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 C. You all make me happy. C, C, yes. Yes, absolutely. You need to disclose this at all levels because again, remember, you as the participant, as I said at the beginning, I introduce myself in multiple ways because there may be different ways in which you and I may connect. If you're a mom and you hear I'm a mom, the way that we'll have a conversation and talk about breakfast may provide a lot of different detail than for the person who connects with me because, oh, I studied biology, you studied biology, now we have a connection, right? And so being objective does not mean you withhold information. It's actually really important for you to share that information. But you can also say this actually gives you an advantage because you have some understanding of the culture or the context. And so when they use certain words that are specific to that area, right? If we say, you know, if I go to Cameroon and somebody was talking about the boot of the car, my US friends who just grew up here would have no clue. And so that might cause some confusion because they're expecting to hear the trunk of the car. But now I can already, when I'm analyzing that answer, I can say anyone who said boot is the same as the person who said trunk because it's the same part of the car. And so my identity or my experience in Cameroon was relevant and actually be in a positive way, okay? So your objectivity is a big deal, but disclosing relationships or familiarity is not necessarily a bad thing. You actually want to put why that could be an advantage, but then you also would want to emphasize how you've triangulated your results so that they stand on their own merit as being credible. So you do want to disclose to the participants, but not only the participants, because IRB needs to know in there, those who are reading your study afterwards need to know, because they can draw their own conclusions. But again, if you're able to show trustworthiness in other ways, it will not adversely affect your results, that you actually are familiar with the context. And you could argue that it benefits the study, okay? Next slide, please. I think we're almost done on Dr. Ngwa, but I wonder, are there any questions that you all have? I think I may have a few more for you, but are there any questions from anyone? Something that wasn't quite clear maybe, or just curiosity? If not, Dr. Ngwa, I think I have a couple. Let's see. How to decide on the minimum number of participants? That is a good question. Sometimes the situation will decide for you. So for example, if you wanted to understand the experience of kindergarten teachers at a particular school, maybe because that school is doing very well or that school is doing very poorly, you may only have 5 teachers. In that case, I would probably want to triangulate by doing 5 different schools. And then that should give me enough diversity in my participant pool. 5 times 5 is just 25 participants. But because I had a specific goal and they had to be schools in the same region, that already, kind of limits how much I can do. But these are conversations that would be affected by the concept you're trying to explore, the size of the population itself that you're trying to explore, the access that you have, because sometimes your access is limited. And just the 10 people that you interview for a very special population in an isolated region is information that nobody else already has. And that 10 could speak volumes. But if you're interviewing a population that's easily accessible and there's already some information out there about them, then you would want to make sure that your critical mass is a little bit higher. Sometimes your literature review will help inform how many participants, because if you see that in the past, people in this field or studying this theme or this population interviewed 20 to 30 people, then you want to make sure you don't interview less than 20 to 30 people. So your literature review may inform, the access you have may inform, availability may inform. So this means that we usually need an experienced researcher in qualitative research to be involved in the project. Yes, yes. Just like, the first time you work on a paper to publish, you may want to partner with an experienced person who's already published, because their experience, they could say, you know what, maybe we should phrase that a little bit differently, or you know what, it's important that we include this or that, or broaden the, the time frame that we're studying. That experience is very helpful. So I would highly recommend that if it's your first time conducting a qualitative study, that you collaborate with someone who's done one before. Otherwise, just do a lot of homework in terms of your literature review so that you can give some good justification for the number that you used. Yes. Absolutely. Thank you. Thank you. All right, don't leave yet. I have a couple of questions for you, Dr. Will. Do we have 5 more minutes or so? So I have 3 quick questions here, and then I have 3 quick questions on a Google form that I will put in the chat for you to help see if we succeeded. Oh, we have plenty of time. Well, then we can start telling stories, Victoria. All right. Is qualitative research less credible than quantitative research? Tell me. Well, I'm very pleased that I see lots of no's, and that is correct. So then my question to you, let's see. Before, could we go back 1 slide? Since we have plenty of time, I can stretch out some things. All right, and so most people, Let me see. 12:45. So, yep, we have about 10 minutes. Okay, beautiful. So again, most of you said no, it's not less credible, and I'm very happy to hear that. And so then my question is, what makes it credible though? Because just because it's another form, that's not what's needed. What are some of the words that you remember hearing that could help make your research, your qualitative research, credible? There were some words that we mentioned, some goals that we may strive for. Could we type a few of those in there? Maybe who can make it credible? What characteristics can make it credible? Reliability. So yes, if I have enough trustworthiness, if that triangulation, and I can rely on it if I know that the participants were recruited in a way that is credible, right? If I know that I have that IRB approval, if I know that my researcher knows what they're doing, so either some research, some training, transferability, yes. So if I'm very specific about my population, then I can cautiously transfer some of the information or the results. Methodology, very important. If I'm able to document my process, then that will give me credibility. Open-ended questions, and then maybe some follow-up so that I can have some descriptions, yes. Because again, we're looking for themes that repeat, we're looking for keywords that repeat, and those are the things we would put together and then say, here are my findings, full disclosures about me as the researcher, here is the process. Being accurate in reporting, absolutely. So my observations, what I noted. So on that day, I'm listening and I'm also taking notes. And like you said, being accurate also means me disclosing I actually lived in Cameroon before. And I would add, I think this makes me a better researcher because I can relate to the people. And then I will emphasize my triangulation. Very good, very good. Next question, please. I think this one is related to something we already asked, but it's so important that I had to ask it again. If you're a member of the community being researched, are you disqualified from conducting the research? Yes or no? Very good. Again, the answer is no. So if you are conducting, other types of research, you want to be as independent as possible. But in this case, it may give you an advantage. The important thing is that you disclose this information. And to that, I would add, and then you emphasize your other efforts to make the work credible, right? I mean, people should see that for themselves, but I typically will go out of my way. I will say how I'm related to the context, to the setting, to the population, but I'll make it very clear the pains I've gone through to make this a credible research. I would make sure I describe my triangulation. I would make sure I mention the credibility of others on my team. I would make sure I disclose any funding, all those things that we normally do. So just because you have a relationship with the community or with the population, that does not disqualify you. Just make sure you disclose and then you emphasize the other things that make your work credible and those things we listed before. And the next one, Dr. Will, if someone starts an interview but decides to discontinue, so they signed informed consent, you have the letter from the community, everything's good, but they start an interview and they decide to discontinue, should their partial interview be included as data? So this one, we didn't really talk about. So I'm curious as to what you think. So most people say yes. No, yes, 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 yes. Somebody says yes, but mention, I think, but mention that they did not complete it. All right, so let me ask you a question and then maybe would it depend on whether they withdrew consent? Not necessarily. They start and then it either becomes, it's too much time and they don't have enough time. They have to go pick up their kids from school and they're not coming back, or it's too sensitive. They realize that it's bringing up emotions they don't want to disclose. It could be for a number of things, but not even if they kept their consent. You should recheck with the patient to see what can be included. All right, so when you conduct your study, your questions are not random and you're not adding questions along the way. You have your semi-structured questions, all of them already, even though you have follow-up questions that you could keep digging, right? So here's the thing. Sometimes we ask question 1, question 2, question 3, question 4 might be related to question 1 to help see whether our patient was consistent, right? Or whether they fully understood. And so you could ask your patient, did you eat anything this morning? And then you ask them something about their day, something else about their day, and then you ask how many meals have you had already? And they put a number that could contradict that first one, then there's something different in how they respond. Sometimes when we're asking interview questions or we're dealing with patients or whatever the population is, by the time they get to the end of the questions, they may be in a different comfort level. They may remember things from the beginning that they hadn't before. And so it's best not to include their partial interview questions because they did not complete the study. And the study questions from 1 to 20, or hopefully it's not 20, it'll be too long with the follow-ups and open-ended, but from 1 to, questions 1 to 7, with the follow-ups and allowing them to talk, that could take a good hour. But if you only include questions 1 to 3, it's not a full picture of that individual or their experience. And so if someone does not complete the study, you should not include their partial answers. And you do need to note that you started out with, 30 participants that consented to participate. And at the end, you ended up with 25 that completed the study. So keeping this in mind, when you're thinking about your minimum number of participants, know that it is normal for some people to leave the study for different reasons. Sometimes they can't, they can't help it. And sometimes they just have second thoughts or they have cold feet or whatever it is. But you want to include participants who fully went through the interview or went through the process. That's part of the credibility of your study. Because if somebody answered 1 or 2 questions and you put it on there, I'm reading your study and then I say, well, what happened to the rest of the questions? Why did you leave them out? Why, and it may sow doubt in my mind. And so I don't even want to have to answer to someone. I would rather say 30 people were there at the beginning, 25 completed all the questions, and only 25 responses are included. So I know that's not something I taught in my lecture, but I think sometimes it's easier to remember something important when we get it wrong. And so it's okay if you got it wrong at the beginning. All right, so I think this brings me to the end of what I have prepared for you for today. I have a request and I would like you to do it right now because you do have, from what I can see, 6 minutes before your break. I will copy this, I should copy this link and put it in the chat for you to answer. It's just 3 questions on a Google form, and it will help evaluate whether we met our goals for today. So let me see if I can find that and put it in the chat. Qualitative research. All right, so I'm hoping this is the right link. I'm putting in the chat. Please take a few minutes. It's just 3 questions. There's not too much there. All right, so there are just 3 questions and I would really appreciate it. Just to be clear on the questions, you're answering 1 to 5. 1 means you do not agree and 5 means that you fully agree. So if you could take just 2 minutes and answer those. One of them is just, I know more now about qualitative research than I did before this session. And the second is my level of skill, how to design a question or a study has improved because of this study. And the third one is I intend to learn more or seek opportunities to be part of a qualitative study. So if you would please just take a few minutes and answer those 3 questions for me or for our team, we would really appreciate it. But thank you so much for your attention, for your participation, for your questions. I really appreciate it. I guess I did not put my email anywhere, so I'll put that in the chat as well. But if for some reason you missed my email, if you contact us through the Global Health Catalyst website, it will find its way to me. So lasana@globalhealthcatalyst.org. Catalyst with an S at the end, .org. lasana@globalhealthcatalyst.org. So there's my email in the chat. If you have any questions, I would be happy to answer. And again, I hope that I will see many of you at our Global Health Catalyst Summit, June 7th to 9th. You can join remotely. And if you're interested in participating, we will have a workshop, a training workshop on just gaining skills for working with diverse cultures, either because the cultures are diverse or faith-based cultures, because that's really important in development work and in global health work. So just the kinds of things that you want to keep in mind to engage diverse participants in development work. And then also the Young Catalyst session, we will have groups from different areas working on different projects. So I know Dr. Laila, we can get a group from this group and share some of the work you're doing in Jordan. But thank you all so much. I enjoyed my time with you.
Thank you so much, Dr. Lydia. This has been amazing and a lot of fun with all the interactive questions and extremely informative. A lot of us know a lot, not a lot, but something about quantitative research, but qualitative research, it's still an area that we need to know more and more about. So thank you so much
You're welcome, my
being
pleasure.
amazingly informative and a lot of fun.
I'm glad to hear, glad to hear. All
Yeah,
right.
I'm so looking
All the
forward
best
to
to
seeing
you. Yes, I hope, I know I have an invitation to Jordan, so I do hope I have the opportunity.
Yes, absolutely. Hopefully soon,
Hopefully soon. Yes, that would be wonderful. All right. All the best to all of you. Take care.
Thank you so much. God bless.
Blessings to you all. Bye-bye.
So it is a great pleasure and honor to introduce Dr. Krishni Wijesurya. Dr. Krishni is currently Professor of Radiation Oncology and Professor of Physics at the University of Virginia. And Dr. Krishni joined the faculty in 2008. She received her PhD in nuclear physics from William and Mary in 1999. And Dr. Krishni is a medical physicist with research interest in new cancer treatment techniques, novel imaging techniques for tumor localization and delineation, simulation modeling, and treatment plan optimization methods to reduce immunosuppression during radiation therapy. She was the principal investigator of a funded clinical trial at the University of Virginia Cancer Center to implement a predictive model for immune suppression, leading to the world's first randomized clinical trial to proactively reduce immune suppression via treatment planning in early-stage lung cancer patients. This work received the Best in Physics Therapy Award at the 2023 Annual American Association of Physicists in Medicine meeting. So Dr. Krishni has research experience also in predictive modeling, artificial intelligence, and radiomic feature-based early detection of tumors, GEANT4 simulations, and Rayyan Amazon cloud-based virtual LINAC simulations. She initiated many clinical programs at the University of Virginia, including total body irradiation, movement management, deep inspiratory breath hold program for left-sided breast treatments. We are extremely honored and excited to hear the lecture of Dr. Krishni Wijesurya. Welcome, Dr. Krishni.
Thank you very much, Dr. Jones. So this is an interesting topic. I've never done this before. So I also did my own literature search. So you will see how it panned out. So topic today is Introduction to Clinical Research, and in particular the literature review. So these are the learning objectives. At the end of this lecture, you should be able to learn how to conduct a comprehensive and systematic literature review and understand the importance of literature review in situating research within the existing knowledge we have today. These are my conflicts of interest. This is my outline. I'll give you a brief introduction and talk a little bit about what is the systematic review as well as meta-analysis. I will talk in depth into process of literature review, how to conduct a literature review, and I would finally give you suggestion how to improve the quality and rigor of the literature reviews that you're performing, and finally give some examples of search engines that you can rely upon to do your own literature review. So, introduction, literature review is an essential feature of academic research. Knowledge advancement must be built on prior existing work. By reviewing relevant literature, we understand the breadth and the depth of existing body of work and identify the gaps to explore so we could add to the knowledge in the world in a particular field. By summarizing, analyzing, and synthesizing a group of related literature, we can test a specific hypothesis and develop a new theory. We can also evaluate the validity and quality of existing work against a criteria to reveal weaknesses or inconsistencies or contradictions. I'm trying myself. Okay. So, since we are dealing with scientific inquiries, literature review should be valid, reliable, and repeatable. So, we need to maintain these three criteria. So there's multiple platforms that we could do research on. We have basic science, basic research, clinical research, population-based research, and health service research. So one helps the other in both ways. So from basic science to the bedside, or the data that we acquire from a clinical trial using actual patients also help to develop new basic science research. So it goes both ways. So it's the translational research. At the end of the day, what our goal is to improve the lives of the patients, and the faster the uptake of credible evidence, the quicker healthcare and health may improve, and the greater the returns on the nation's research investment. I think that is why we are here today, to talk about how to improve research in terms of literature search. So literature review can take two forms in a very basic level: background reviews and standalone reviews. Background reviews, commonly used as a justification for decisions made in research design, provide theoretical context or identify the gap in the literature the study intends to fill. On the other hand, standalone reviews attempt to make sense of a body of existing literature through the aggregation, interpretation, explanation, and integration of existing research. So what is a systematic review? So I took this quote from this paper: a review that is conducted according to a detailed and comprehensive plan and search strategy, derived a priori, that means before, with the goal of reducing bias and errors by identifying, appraising all relevant studies on a particular topic. So there's a lot in this sentence. So we will try to break it down. So what is the significance of systematic reviews? So there's a large amount of medical literature every single day that is accumulated across the world, right? So the clinicians and researchers alike to rely on this data. They need to have systematic reviews because no one has the time to sit down and go through all the literature when they want to really find out what's the best way to treat a given patient for a particular cancer stage, for example. So to make an informed decision, they like to see this type of systematic review performed. That again, systematic reviews minimizes the bias. A systematic review is a more scientific method of summarizing literature because specific protocols have been used to evaluate the data across the world. So as I said before, since there's such a large volume of published material, makes it impractical for an individual clinician to remain up to date on a variety of common conditions. This is further complicated when individual studies report conflicting conclusions, a problem that is prevalent when small patient samples and retrospective design are used. Retrospective meaning not prospective trials with the clinical trial, going back in time. Patients they have already treated, so you get a sample of patients and do a study, and those are called retrospective studies. So key characteristics of systematic reviews: they are clearly stated titles and objectives, comprehensive strategy to search for relevant studies, can be unpublished and published, preferably published, explicit and justified criteria for the inclusion or exclusion of any study before the study is begun, clear presentation of characteristics of each study, included an analysis methodological quality, comprehensive list of all studies excluded, and justification for the exclusion. These are all characteristics of systematic review. More to continue, clear analysis of the results of the eligible studies. So this could be using meta-analysis, statistical synthesis of data, if possible, or qualitative synthesis. Structured report of the review, clearly stating the aims, describing the methods and materials, reporting the results, and publishing that work. So that completes the full cycle of a systematic review. So all these components should be there for a systematic review to be a success. So again, this is very important, so I'm reiterating it here. Advantage of systematic reviews reduces bias. It is replicable. You can replicate it if you were to do a new study. Resolve the controversy between conflicting studies. Identify gaps in current research. Provide reliable basis for decision making. So of course there are limitations to systematic reviews. Results may be inconclusive after you are done with the study. There may be no trials or evidence for you to rely upon to do your study. The trials may be of poor quality. The intervention may be too complex to be tested by a trial. Practice does not change just because you have the evidence of effectiveness or effect or the effectiveness. These are all limitations of systematic review. A little bit about the meta-analysis. I actually have a graph showing the hierarchy later in this talk. So meta-analysis actually established in 1976 by Glass. It's a statistical technique for combining the results of independent but similar studies to obtain the overall estimate of the treatment effect. This includes extracting the summary statistics common to each study to serve as a dependent variable. This is usually effect size, and moderator variables to serve as independent variables. This is a characteristic of meta-analysis relies upon statistics. The synthesis of a meta-analysis will include a meta-regression and explanation of the results. If a meta-analysis is to be included in a systematic review, an experienced statistician or epidemiologist should be consulted during all phases of the study. So I'm giving as much as possible the references if you were to get this talk later on, so you can always refer to it. Here's a hierarchy of evidence that organizes clinical research based on study designs and classification level to each design. So bottom of the list is the background information, expert opinions, and guidelines. And then you have the individual case reports, then the case series of studies, cohort studies, then non-randomized controlled trials, randomized controlled trials comes next. Critically appraised literature evidence-based practice guidelines comes top 3. Systematic reviews, and the best is the meta-analysis. So you can see the hierarchy of literature that if you are to, let's say you have a topic that you want to do a study, you are planning on conducting a research or a clinical trial, you are trying to collect what is out there, how can I, what gaps are there, how can I try to fix them. So you should kind of look, when you're doing a literature, always keep in mind, what are the best papers to look. So when you are looking for meta, if you can find literature on meta-analysis already available, that's a great place to start. So systematic reviews and also the evidence-based practice guidelines. So you can see what is the current situation. So you can try to see, is this enough or can we make it better? So I would try to steer clear of the lowest level of the literature that would not really help you move forward in a good pace. So process of literature review. Literature review process can be iterative in nature. While conducting the review, unforeseeable problems may arise that requires modification to the research question or the review protocol. An often encountered problem is the research question was too broad and the researchers need to narrow down the topic and adjust the inclusion criteria. So this is why I said, yes, it's an iterative process. So you need, before you embark on the process of literature review, you do not know what's out there. So therefore you will most probably, you will have to go back to the drawing board and refine your criteria, define your protocol a little better to see what you can access. Various types of reviews do differ in the review protocol, selection of literature, and techniques for extracting, analyzing, and summarizing the data. So here are the 8 steps that's been described by many as the components of a systematic literature review. First, you have to formulate the problem. Then you have to develop and validate a review protocol. Then you have to search the literature, screen for the inclusion criteria, exclude the ones that are matching with your exclusion criteria, assess the quality of the data or manuscripts, extract the data, analyze and synthesize the data, look at the statistics of the data, and finally report the finding. So here's a diagram, a flow chart showing that same thing. So it's been divided into 3 categories: planning the review, conducting the review, and reporting the review. So all 3 are equally important. So planning the review, step 1 is, as I said, formulation and the development of criteria, protocol. Conducting the review is the main part of the 8 steps. It includes 5 of the steps: search, screen, inclusion criteria, assess the quality, extract the data, and analyze the data, and finally reporting the findings. An author of a good systematic review formulates the question correctly, conduct the literature search, refine the search by applying predetermined inclusion exclusion criteria, extract the appropriate data, and assesses the quality and the validity, synthesizes, interprets, and reports the data. So formulate the review question. How would you do that? First stage is define the review question. Second stage is forming hypothesis. Third stage is developing the review title. It's often best to keep titles as short and descriptive as possible by using the following formula. This is just a guideline. You can say, I have put the things in red that you can change. Intervention, it can be radiation therapy, or it can be a surgery or something like that. For the population, are you looking at lung cancer? Are you looking at pancreatic cancer? Or you're looking at pediatric patients? And with the condition, what is the condition you're looking at? So you can try to start with something small and descriptive like this to try to example dialectic behavior therapy for adults and females with borderline personality disorder. So this is one place to start to formulating your title and the hypothesis. So develop and validate the review protocol is the next step. It is a preset plan that specifies the methods utilized in conducting the review. The review protocol is absolutely crucial for rigorous systematic review. I have given some references here that you can get more understanding of what to look for. It's necessary to enhancing the quality of review because it reduces the possibility of researcher bias in data selection and analysis. I'll go more in depth to talk about the bias from different categories. It also increases the reliability of the review because others can use the same protocol to repeat the study to cross-check and verification. Define inclusion and exclusion criteria. So I have given some examples here. One is the PCOC, the Cochrane acronym PCOC, which stands for Population Intervention Comparison Outcomes, can be useful to ensure that one decides on all key components of prior to starting the review. So you have to define your inclusion and exclusion criteria, possibly with one more researcher, not alone, before you start the literature review, so that to reduce the bias. For example, authors need to decide the priority in the population, age range, conditions, outcomes, and the types of intervention and control groups. It's also critical to operationally define what types of studies to include and exclude. So are you going to look at randomized controlled trials? Or are you going to look at qualitative research or quasi-experimental design? So it depends on what's out there and what is the best you can get. So that's why I said it's an iterative process. The minimum number of participants in each group, or published versus unpublished studies, and the language restrictions. So first, focus the question. The structured question will determine the inclusion-exclusion criteria. What is the population of interest? What are the interventions? What are the outcomes of research? What study designs are appropriate? So here are two quotes. Once a study question is formalized, the authors must compose a comprehensive list of inclusion-exclusion criteria. To avoid selection bias, inclusion-exclusion criteria should be agreed upon and formalized before data extraction and analysis. So a comprehensive and reproducible literature is the foundation of a systematic review. So how do you identify the literature? So you can use different keywords. When I at the very end of my talk, I will show you some literature search database engines. So we can pull up any of those. You should always try to use multiple database engines, search engines to do your literature search, but you should have character strings, keywords to first start somewhere. Then you can look at those literature and then look at the references in the literature and go in depth into multiple different branches of that under that topic. So you use multiple database search engines, limit the publication date to most recent, because if you are in 2024, you don't want to look at something that was created in 1968. Of course, there are some publications that are really has high impact publication that has defined the field. I'm not talking about those ones, but many times it's good to stick with the last decade or even more recent when you are trying to establish your research topic. For each manuscript, determine the primary relevance by title. Just look at the title first. From the title, if the content seems to discuss the topic of interest, then you go in depth to look at the abstract. If you think this is relevant for your work, your topic, obtain the full reference, including the author, year, title, abstract for further evaluation later. Utilize the forward and backward search to identify additional studies. So I actually touched on this thing a little bit earlier. So you can look at one manuscript and go to the references and go back and look at other studies, and going back and forth sometimes helps to get additional studies that you might miss otherwise. So screening for inclusion. When it comes to the overall screening procedure, many suggest at least 2 reviewers work independently to appraise the studies, matching the published review inclusion exclusion criteria. So this is a good practice. So for when you do a study like this type of study, you will at the end of this talk, I will show you that there are points given for different analysis. So if somebody is to pick my clinical trial that I just completed running, and when they read my paper, they will see what have I achieved. Have I had multiple authors looking at this data? Is it a randomized trial? Is it been double blind? That type of thing. So when you are conducting either clinical research or a clinical trial, it's good to know these things so that you get it right the first time. It helps. So and so there should be at least 2 reviewers working on a given project, so reduce bias. So one recommend that at least 1 reviewer be well versed on the issue of the review. However, having a non-expert second reviewer could be beneficial for providing a fresh look at the subject matter. So sometimes we say it's good for you to, even if you're writing a grant or if you're writing a paper, give it to somebody who is not so well versed in that topic, because if you are creating new material, it should be ultimate goal is for the reader to understand what your work. So therefore, it's good to have somebody who's not a super expert in your study to be the other person. The appraisal is commonly based on the abstracts of the studies. In case the abstract does not provide enough information, one could also read the conclusion section. So those are the main things. Read the title, abstract, conclusion, and see whether this is actually giving similar to the other papers that you have collected or something complementary. So to add to your group of literature. So the individual assessment should be inclusive. If in doubt, always include the study. If you are not sure whether it actually has, by just reading the abstract and the title, add it. So later on, when you meet up with the other reviewer, you can read the whole manuscript and decide whether it has relevant information. And at that point, you can try to remove that if it still doesn't meet the criteria of your eligibility. In case of discrepancies in the assessment results, which are quite common, the 2 reviewers, at least the 2 reviewers, remember the 2 reviewers should resolve the disagreement through discussion or by a third party, and note what you have, how you came to that conclusion. Again, in doubt, include studies for further examination. So quality and eligibility of the assessment. This is extremely important. One of the main parts of your research, literature search. Only include high quality report with well-cited references. Normally when I do a literature search, I go to high impact factor journals to see what I can find. Nature Reviews is one of them, or New England Journal of Medicine. That level high impact factor journals, those have, and especially review articles. If you are not clearly sure about what others have done, they nicely summarize these review articles that you can, if you can get in your topic, to understand the process. I can give you an example here. So as I was presented this afternoon, I'm a medical physicist, but I ran a clinical trial in immuno-oncology. So one might wonder, how did that happen? So I think I thank the literature search. So I educated myself. I started from scratch, and then it allowed me to understand the immunotherapy and immuno-oncology biology. That led me to read more papers. And when you start from somewhere, you can ask the right questions. You can direct to the where you want to go and learn something new, and then it becomes much easier. And so you can at that point you can go and either go to some sort of the pre-meeting courses like Astro. So you can try to get more knowledge on a given field if you have the interest. So right now, I feel like you all are in a very good time to do this kind of research because of the online nature of all of the literature. So it's up to you to decide how far you want to go. It's all available. So a quality and eligibility assessment, so only into the high quality reports and well-cited references, because you don't have much time. So when you have to use the time is as a sense, try to use it productively in terms of getting to the best quality data, best quality papers, so understand the depth and the breadth of the problem. Skim through the full text articles to further evaluate the quality and the eligibility of the studies. Journal articles and books published by reputable publishers as high-quality research. Include them in your review. Technical reports and online presentations. I would steer away from these ones because they are not being gone under a peer review process. So quality assessment, the validity of the systematic review ultimately depends on the scientific method of the retrieved studies and the reporting of the data. So randomized controlled trials, I abbreviate it as RCT here, are considered to be more rigorous than observational studies. A review based on well-designed randomized controlled trial will likely be more valid and accurate than a review based on observational studies or case reports. So keep these things in mind when you are doing a literature search. So because normally you can go at the high level, go down, and you can decide at what point you want to stop accruing literature to your topic, because you don't want to get your uncertainty gets higher and higher when you go lower and lower of that pyramid. It's a good place to if you are looking for ideas. It's good place to see what others have done and even failed or not given enough data. It's a good place, but I don't think that's the way to go if you are really trying to see what's out there in terms of the best in terms of literature. So the most common way to assess and report study quality has been using a composite numerical scoring instrument. It always boils down to statistics. So more than 35 different quality assessment instruments have been published in the literature, and most are designed for randomized clinical trials. And these are very, I have an example later in my talk, very easily accessible for anybody. So you can rely upon these statistical parameters to define your own quality of the quantifiable quality of the literature search. So the data collection, the list of data to be extracted should be agreed upon a priori consensus during the design stage of study. So you cannot change it depending on what data you're going to. You're going to stick to what you decided with the other reviewer and follow that path. So collected data should include study characteristics, sample demographics, outcome data. If necessary, design a review-specific data extraction form. It can be a digital form, so that the same data are extracted from each study and missing data are clearly apparent. When you do a study with many different characteristics, it's always a good idea to add this into a spreadsheet, so you would see right off the bat where's the missing data, what do I have to work. So maybe that is your project if you find there's a big gap in some part of the study. To ensure that the data extraction is accurate and reproducible, it should be performed by at least through independent readers again, not just coming up with the protocol design. The review should also, it strengthens if you have at least 2 independent reviewers. From each study, extract information on the topic. The literature review process is further broken down to subtopics of forming the research problem, developing and validating the review protocol, searching the literature, screening the inclusion, assessing the quality, and extracting the data. So selecting studies, keep accurate records and track them. If you remove something, keep a digital record of it. Give a summary of the total number of records identified in your search. Identify the number included at each stage of the screening process. Provide reasons for any articles excluded when assessed in full text. Present the Prisma flow diagram. I'll talk about this in a little bit. Keeping records complete. So here's a Prisma statement. So you basically make like a flow chart. You start from the identification, then you screen, then you have the eligibility, and you have the include. So it goes down, records identified through database search, how many? Additional records identified through other sources, how many? Records after public duplicates are removed, records screened, records excluded during the screening process according to your eligibility criteria. Full text articles assessed for eligibility, full text articles excluded for the reason, and give the reason. Studies including the qualitative synthesis, studies included in quantitative meta-analysis. So here's an example of that. So 67 records identified through database searching, 7 additional records are through other sources, 7 records after duplicates removed, 72 records screened, 36 excluded, and you say here, see, not a randomized clinical trial, no control group, clinical trial. So that's why they have been excluded. For this example, I'm just giving you an example. And then 36 full text article assessed for eligibility. And then again, 20 excluded. The reasons are given. And then 16 studies included in the qualitative synthesis and 16 studies in the meta-analysis. So there are multiple ways you can evaluate the trials. So here, some of them are given here with some references. There are ad hoc methods. There's a jaded score, Delphi method, consort standard of reporting trials. These are all defined and by consortiums in clinical trials. Cochrane collaboration. So these are different ways of evaluating the given trial. So I'll talk a little bit about the jaded score here. So here, by the way, so this is the article that I am referring to in terms of different techniques that you can adhere to when you are evaluating the clinical trial, the research study quality. So I just put it up there if you are interested in. So jaded score is one of the criteria. So it's actually the point technique I described earlier. It's basically if you have the study is randomized, randomization gets 2 points. So you get 1 point if study is described as randomized, and add 1 point if randomization method is described and appropriate. For example, if you are doing a randomization, you should have a random number generator. So that's how the normal statistical Department of Statistics normally helps you with the randomization. And deduct 1 point if randomization described is inappropriate. So totally you should get 2 points randomization. And double blinding studies. So 2 points possible. So 1 point if study described is double blinded. At 1 point if methods of double blinding described inappropriate. Deduct 1 point if double blinding is described inappropriate. So withdrawals. So if the clinical trial that you're looking at is shown that okay, the patient dropped out of the study. So they have given the numbers and the reasoning and all. You can add another point for withdrawal. So these are things that when you are coming up with your own clinical trial, or even if you are studying somebody else's work, to give this is how you define the quality of the work. So this is like a grading system. So more, you can see the jaded was defined by this author in 1996. So here's an example of a jaded score. So there are 5 studies here. So the randomization, this one got both points here. You can see they got 1 for blinding and 2 for dropout. So you can see by looking at these 5 studies, you can see, you can add these points to see which one is which ones are according to your criteria and what you want to keep versus what you don't want to keep. So there are challenges of literature search as well. There's database bias. No single database is likely to contain all published studies on a given subject, right? Publication bias. Selective publications of articles that show positive treatment of effects and statistical significance. So is it important to search for unpublished studies through a manual search of conference correspondence and search for clinical trials if you do see publication bias? And furthermore, you can have language barriers, language bias. So English language bias occurs in reverse case, exclude papers published in language other than English. So citation bias occurs when studies with significant or positive results are referenced in other publications. Compare these studies with inconclusive or negative findings. So these are different types of bias that you do not want to add to your own study. So if you know about them, you can try to correct them using different techniques. So here's how some ways of minimizing the bias in selection. Okay. Pre-specified inclusion criteria helps you stick with what you plan to do. Considering study design as inclusion criteria. Independent study selection. At least 2 people doing the study from the defining the title, defining your inclusion exclusion criteria, as well as looking through the literature, picking up the titles, the abstract, and reading up the rest of the selected papers on the text of the paper to define whether you should keep it or not, and talk with the 2, at least the 2 reviewers, which ones, if they have any disagreement. And then you can also have statistical techniques. So I don't know whether you can see this. It's a little small in word text. So I have listed on this the table, and it shows that is the risk of bias in included studies. So the left-hand column is the type of the bias. Middle column is the description. Last column is the relevant domains in the collaboration's risk of bias tools. So I have selection bias, performance bias, detection bias, attrition bias, reporting bias. There are different types of bias. Systematic difference between baseline characteristics of the groups that are compared. That is the selection bias. Performance bias is systematic difference between the groups in the care that is provided or in exposure to factors other than the intervention of interest. For example, so this example for performance bias would be we are dealing with patients, right? So we are trying to, let's say we do help patients who are long-lived. Let's say somebody is doing a study on that title, and then you can have biases from the population because people who exercise, they are normally health-conscious patients. Those are the ones who are going to eat well, have a balanced diet. So right off the bat, you cannot distinguish the 2, right? So there's a bias. So detection bias, systematic difference between groups in how outcomes are determined. Attrition bias, systematic difference between groups in withdrawals from a study. Okay, maybe because, for example, patients who cannot afford to come to the clinic every day for blood draws, not every day, every month for the blood draw or post-treatment imaging, because they live so far and they cannot afford to do that. So that right there is a bias, right? You are biasing the patient population based on what their circumstances are, which is monetarily or other. Reporting bias, systematic difference between reported and unreported findings. So these are different types of biases, and then it can lead to inclusive outcome data, selective outcome reporting, and blinding of outcome assessments, and other potential threats to the validity of your study. So bias due to missing data. So I actually have a plot later on, I'll show you. The type of missing data is important to know. Reason for missing data is important to know. Intention to treat analysis would help you try to understand the missing data. Sensitivity analysis, leave one out analysis, imputed data, those are all ways of trying to address the missing data in a given study. So here's an example of reporting bias. So there are author beliefs, word restriction, editorial approvals, peer review, published reports. These are all different kinds of bias that you can have in a study. So for example, if I am trying to publish a radiation therapy manuscript, it can affect the surgery population or the reviewers in the surgery group. So right then and there, editorial approval will be a problem depending on the journal I'm trying to get published. So these are all different types of bias that we live today in many different biased opinions. So therefore, the best we can do is to use statistical, independent, quantifiable techniques to reduce that bias. So addressing the reporting bias. So here's an example. Comprehensive search of the literature reduces the bias. And you can also use a funnel plot. So funnel plot is a risk ratio as a sample size. So you can see here in the left-hand plot, you don't see any big gaps. But if you look at the right-hand plot, the same kind of plot, you can see there's a big gap right here where this circle is. So you can see, you can identify by plotting this kind of funnel plot where the gaps are trying to, or where the biases are trying to address this thing. So it helps you first realize where the problem is. Try to find the data to match them. So when you after you access your data and you decide which ones you want to keep and your analysis, you can try to use different software. Always try to use the technology available rather than reinventing the wheel and spending a lot of time things that you really don't have to do. So use the technologies and software that's available. So in facilitating the systematic reviews. So rely on software for assistance in managing your bibliography, citations, and references. Some examples are given here in Note, Refer, Zoreto. Many databases nowadays allow search results to be downloaded directly into reference management software. It's all digital, right? Nowadays, we don't go to the library and read a book and get read papers or even the journals. They're all online. They're all digital. So that's really nice. So it helps us move forward faster and accurately. So it reduces the errors as well. Many databases allow search results to be downloaded directly into reference management software. So Web of Science, Scopus, they all allow you to directly get that data into the software, but bibliography formatting software. Also, software can be used to code qualitative and quantitative studies to nodes over a topical area. So remember I said after you gather your data, literature, you need to evaluate the quality of the data or use some statistical analysis to evaluate what you have collected and where are the gaps. So there are software that you don't have to really write your own. And also, as I was mentioning in the very beginning of my talk, to this kind of studies, you should always rely upon or add a statistician to your project. It helps immensely to steer away from problems in the later stages of your project. So even if you have that, probably he or she would use these tools. It's good to have these tools available. So some of them are here. So it's basically you can use these quantitative tools to evaluate the quantify the accuracies and statistics of your collected data. So it can also pull out the relevant quotes in the topical area or not for all paper sciences. So this will allow automatically, if you put a character string, it will look for those things, accumulate the data, so you can look at how many papers actually discuss this. For example, let's say a radiotherapy toxicity from lung SPRT. So how many of them talked about this particular toxicity, radiation pneumonitis? So how many of them have? So you can look at these papers using the statistical software, and rather than you going by hand, reading one by one and trying to quantify them. So multiple reviewers could conduct, manage, and document systematic review. So this is help too. Like nowadays, you can, just like you can edit the same paper by multiple people at the same time, reviewers could also manage and document. The systematic reviews could be also done by software. One of them is actually Summary, given here. So there are multiple search engines that you could use to get your paper, look at the abstracts, and as I said before, always stick to the higher level journals, high impact factor journals. So some of this is not an exhaustive list, but some of the things I listed here I use on a daily basis. Google Scholar, Web of Science, PubMed, NIH Reporter, Globacon, if you are looking for international studies, clinicaltrials.gov, if you are thinking about a clinical trial, you want to see what others have done. Same thing with the NIH report. If you are thinking about a research project, you should always go there and see what others have done, what's missing, and we don't want to do the same experiment it's been already done, right? So things like that. So let's look at some examples of websites. So this is the PubMed. So you can go and just on your website, you can say PubMed, it will pop up this National Library. So you can put some topic. I just put radiotherapy related toxicity and search, and you can get all the examples. Here's what I got. So I got I did not put a timeline first when I punch in the topic. So I got everything from 1960 to 2024, and whole host of papers came up. And then I wanted to go and reduce these results, because I got like 9,885 papers, which doesn't seem like a good idea. So then I went and searched for time between 2018 and 2024, and then it reduced to 3,840 results, so you can see. And then I also went and added clinical trial. I want to see what kind of clinical trial it is. Remember, we talked about this, right? The papers that are most important are the systematic reviews, meta-analysis, and clinical trials. So I put this one, so it actually reduced it to 589 results. So similarly, you can put meta-analysis, you can put randomized controlled trials, and you can also do, not here, I think in another one. So actually there is one, see, you can see systematic review. Reviews are really great places to start. If you're beginning on a topic, you can learn so much about that topic rather than going to so many different places, and then you can improve your level of understanding of that topic and then start looking into meta-analysis and other things. So randomized controlled trials, So you can check on any of these things. If you don't want the whole papers, just put the abstract and the title. And then when you're happy, you can go and put the full text and try to download that into or directly connect to your bibliography. So systematic review, as shown here, it reduced to 208 results. So I just picked one of the first ones in a systematic review here as an example to show you what they have done. So this is just an example. You can go pick some other ones. So adverse events of immune checkpoint inhibitor therapy for urologic cancer. So the paper was in 2022, not bad. So it's also from European Urologic Journal, which is a good journal. So if you're not sure, just go and Google the impact factor of the journal that you're looking at. It will tell you what it is. So to for example, impact factors of Lancet is for 168, or New England Journal of Medicine is like 176. So those are the top journals that in medicine that you can then basically go and look at the other papers to get an idea about the impact factor. So so you read the abstract and the title, and if it is matching what you want, you can add that to your list. So here in this journal, I just highlighted some text. I don't know whether you can really see these ones. So in yellow, it tells you they looked at this analysis between 2010 and 2021. So it's a decade worth of data in here. And they say how many they identified the records. They're doing a literature search themselves. So how many they found 2,600 records, and then you have 92 studies. So and then that match their inclusion criteria. So this is what we just talked about, right? How to do research, systematic review. So they use the PubMed and Embase for search for the published clinical trials from that range of times, using the combination with Boolean operators on all of these character strings. Remember, I said that you need to put character strings to search for what you're looking for. They tried a lot of different things: PDL1, anti-PDL1, all nivolumab, pembro, all of those things. So you first need to know. Like I said, first you need to know what to look for. So if you are not sure, you can always go back and look at a review article or 2 or 3 on that topic, and then understand what characteristics you can actually look for to get that kind of literature. Okay, and then you can see. Remember, I talked to you about these things. So they basically define their selection process, which is a good thing. These are, you get point when you see papers like this. You can add the numbers to your points to your that paper. So you can see they have identification, screening, eligibility, included, exclusion. All of them are with number of patients, number of studies. They have nicely placed it. So here you can see all of the different the regression analysis statistics that they have done using that data. So they look at the cancer type, combination type, CTLA4, anti-PDL1, and then grade of the toxicity. All of those things they get gathered from that literature search, and summarized even more: cancer type and the combination type. And another one is I quite often go to NIH Reporter to see what others have done in terms of a given clinical trial. So again, you can just Google NIH Reporter, and then you can go and put whatever you want. I just punched in hypoxia and radiotherapy in the title, and then I got this. So, and then you can read the abstract, and this you can say it's from the UT Southwestern, and who is the PI of the project, what is the project number, how long it's going to go, when did it start. All that information is given here, and you can read a brief abstract on the material. So, and then you can go and look at the different publications on this topic. So hypoxia and radiotherapy. So I got a whole bunch of things here. See, oxygen sensitivity for F-MISO, an MRI for prostate cancer, carbon ion radiotherapy, heterogeneity of the radiation response. So I see these publications and the year of the publications as well. So it goes, it's just one screenshot here, but it goes on and on and on. So you can try to get these publications because they are funded research that you can actually get a good idea about what others have done. So Nature Reviews is another common place I go. Nature Reviews gives, again, it's like a review article, so you can go and read and see a given topic. I put cancer vaccines, the next immunotherapy frontier. So I can go and understand what others have done and try to stick with latest research work. So so you can see here, it basically shows me a picture of how the CD4 pluses and CD8 pluses work in the environment of the cancer microenvironment, and how you can create an vaccine, in situ vaccine over here. So you can see, so if this is not your field, I'm just telling you that even for somebody very from a different background can read these things and learn. I'm just telling you that there's so much out there right now. By doing a literature search, you can learn so much, and you can just jump into a field that you really want to go and do well. So Nature Reviews articles are really good in that sense. So it kind of summarizes all of the great work from high impact journals and concisely writes the basics of a given topic. So Google Scholar, I already talked to you about this thing, radiomics. I just went and punched in some title, radiomics for detection of lung cancer. So it gives me like whole host of papers, and it tells you the year and the author list, and also it tells you, if you are interested, if you go and click on this one site things, it can give you the references right there and there. So you can play with the time here, and you can also click on the patent if you want to know whether anybody has patented any of the work. So there's a lot of tools out there that you can do a comprehensive literature search on any topic that you wish to do. So so you can see I went and click on the citation. So here we go. I can get any format to add that to say in note or refworks, all of these, you can just directly add them. So another way review articles is, so it basically tells you review article information of CD-based screening for lung cancer. So this is a review article. So as I'm not stressing enough, I sometimes feel like review articles are the way, it's the way to go if you are new to a field and you want to know what is out there and the top level research. So so you can walk you through the workflow of the radiomics, for example. Here you can see this review article. How do you do a radiomics study? Okay, you take the imaging data, you contour your nodules, you extract your radiomic features, and it tells you what they are, and then you can say, how do you use this data to create a model, machine learning model? So it just walks you through. So it's gaining knowledge through this kind of research is very easy nowadays because of the digital world we live in. So it also shows more how the pre-processing and post-processing data that's involved in a study like this. So, and then you can go and put highly cited papers. See, this is actually, I'm sorry, it's cut out here. The Web of Science. So I went to Web of Science, and then I checked on, I just went and put some radiotherapy to lung. And then it gave me a whole bunch of 966 studies. And then I went and refined my search by putting highly cited papers. So you can see here, this paper, this red thing is the highly cited paper. So it's actually 560 citations. And it was in Nature Medicine. So things like that. So you can look, when you do these studies, you'll understand the different characteristics that you can use in these different search engines to get what you want and stick with the best of the literature rather than wasting time on the bottom of that pyramid. So again, if you are looking at global data, world data, so I would go to GlobalCan. So you can again go and get data, spreadsheets, plots, swimmers plots, all sorts of different plots for any topic you want to know, whether it is this one is for cancer, so there are similar websites for other disease sites as well. So here I went and put in here age standardized rate. So I compared Jordan versus North America just for fun. So you can see per 100,000 people the comparison for different tumor sites, the incidence. So you can do a lot of things here. You can go and play with these different incidence, mortality, male, female, countries, continents, all of those things. So if you are interested in that type of research. So clinicaltrials.gov is another one I go to see what others have done, what kind of clinical trials, how can I access the data, how can you, is that clinical trial complete for accrual, is that clinical trial had to stop early because of some toxicity. So there's a lot you can learn from going to these different websites to learn and to make research, medical research, easily accessible, easily conduct easily, as well as stick with accurate, high level work. And so yeah, I went and put in here lung cancer again, so you can see the results I got. So about there are 11,952 studies. That's just way too much. So I went and tried to reduce the number of parameters by adding a different search criteria here. So here's a study overview that I was looking at, validating artificial intelligence effectively find lung nodule prevalence score in patients with pulmonary nodules. So I can read and see what they have done, how they screen their patients. And this is a study that was done across the world: Philippines, Malaysia, Saudi Arabia, United Arab Emirates, Kuwait, Thailand, Hong Kong. So it's nice to see that this study has been done in multiple continents. And then what did they use? They used an algorithm to predict to the lung, to look at the pulmonary nodules in lung cancer, because we know that lung cancer early detection is will lead to higher rates of cure. So how would you try to improve the situation other than just using radiology, CT scan with the naked eye? Can you use an algorithm? So you can see there are certain things that already been done. So it also shows the nodule sizes that they looked at. So a lot you can learn. So unique website to get. I sometimes go to look at toxicity stuff at IAEA. Let's say I want to look at the radiation related cell death or typical, okay, let's say proton therapy related immune suppression. So I can go to IAEA and get that data just like any other. This is not a common place. Many people would not go here, but sometimes I do, because different websites give, IAEA, for example, gives you the safety protocols and trials and things like that to the world, especially non-US countries. So I like to conclude. Take home points. First, when you are doing a research, a clinical research, a comprehensive study, first start with a research question. Second, choose a review type suitable for the review purpose. Third, plan before you leave. Developing a review protocol is a crucial first step. for rigorous systematic reviews. So think carefully when you are developing your protocol and try to add another collaborator for your project. It will help you become a better researcher as well as your project will do well. Fourth, be comprehensive in the research and be aware of the quality of the literature. Assess rigor and the quality. So stay higher in that pyramid that we talked about. Fifth, be cautious, flexible, and open-minded to new situations and ideas that may emerge from the review. Because as I said before, when you make a digital spreadsheet of what you have found, sometimes you will get surprised from where the missing data is, for example, can lead to why there's missing data. And also you might find new results that unless you do a comprehensive study, nobody will find out the added nature of that kind of research, what you find. So you might find out maybe the cardiac, I'm a radiation oncology physicist, so I always think in terms of radiation damage, but it can apply to any other field. So for example, when I'm looking at some data, when I put the metadata together, I might see, I'm talking of breast patients, I'm putting the lung patients, I'm looking at esophagus patients and put them all together. I do this research, I suddenly find out from my statistics, my God, cardiac dose is leading to overall survival reduction. So this is just an example, I'm just throwing it out there. So like that, you should be open to what the data tells you. That's the whole point of doing the study. Data defines everything. So your results will tell you something new. So, but please be open to that result that you're going to get. 6, document decisions made in the review process. That is extremely important. And lastly, teamwork is encouraged in the review process. At least 2 reviewers work independently. Will give you great projects and great results that you can publish. Thank you. Any questions? I know that this is a platform to ask questions, but I'm happy to take any questions for the next 6 minutes.
Thank you so much, Dr. Krishni. This has been amazing, comprehensive, and I think we look forward to receiving the slides because it has a lot of very important information about different resources that can be used. So really, thank you so much. We can look at a few questions in the chat. There was a question about whether to use AI in a literature review and how to do it, like the ethical use of AI in literature review. So that was a question. And I'm going to go through more questions.
Yeah, that's a good question. Thank you. It's actually a very good question. So the thing is, for example, AI ChatGPT. So you can go and put a question and say, can you give me some references for toxicity in liver cancers or something like that? So it might give you some references, but you have to go in there and double check these references. And also there's another part, the AI might not been updated the way it's supposed to, and there might be gaps in it. Remember, so you have to, it will not give you a comprehensive study. So you need to be aware of that fact.
Okay, great. And there was another question about what would be a good number of references per study?
Good question. That's a good question. That's a hard question to answer because it depends on the study and what you are looking for. If it is a very broad study, for example, if you are looking for, let's say, when I am doing a study, for example, I can tell you my personal experience. So I would have about maybe 60 to 70 papers, then I would look. So, but that is a study that I would do if I were to write a clinical trial and then try to use that information, looking at different aspects. So, but if you are trying to write a paper on, let's say, less breast cancer, radiation therapy related toxicity, I would think 20 papers, high level 20 papers that already have the reviews would be sufficient.
Thank you so much. There is another question about whether scoping reviews, systematic reviews can be used as references for a study.
Scopus, is that what the word is? That a Scopus review?
Like, can they use among their literature search, if they want to reference papers for like a prospective, retrospective, or a comparative study, can they include systematic reviews and narrative reviews as part of the literature review and references? That was a question from the audience. So I think
they can, but they would, unless you have better reviews, I would use them as a last resort.
Okay. And then we have a lot of engagement from the audience thanking you. A lot of very, very positive feedback with a lot of gratitude. Let me go through more.
I'm happy to do that.
Yeah, a lot of thank yous. Okay.
Thank you. You're
There's a
welcome.
question. Somebody posted a question whether there is a good resource to learn how to write a protocol.
Yes, there's a lot of resources. So I actually didn't touch on that. I apologize for that. So first I would recommend if you are from an institution or a youth hospital-based institution or something, medical school, so to first and foremost go to your IRB, institutional IRB. So they normally have already made up, for example, UVA, we have the IRB provides these websites that we can add some things, and then it'll automatically populate certain things and give you like a skeleton of a protocol that you can go and edit later on. It's a good way to start rather than, because protocols, depending on what level it is a phase 1 study, randomized study, phase 2 trial study, multi-institution study. So depending on that, it can be it can become very complicated. So it is a very good resource to use. But you can also go to clinicaltrials.gov and then try to get like already written up protocols and examples like that. So that is what I can say about the writing of a clinical trial or the protocol.
Okay. There's another question. If someone is interested in a specific area, would you recommend reading books regarding this specific area first, or reading review articles like as a starting point? What would be more effective?
Yeah, if you want to save time, I would tell to go to review articles.
Yes.
Review articles that are already with high impact journals would tell you a lot, and then the references of that can give you to where you want to go faster. And also for the earlier question, I just thought of adding, for example, if you are thinking about writing, let's say, a prostate cancer protocol or a lung cancer protocol, go to National websites and then try to get a standard national protocol. And then you can create your trial to be somewhat like that, but remove the stuff in it and put your own.
Can a systematic review be a base to build on when conducting meta-analysis?
Say that question one more time, please.
Can a systematic review be a base to build on when conducting meta-analysis? Like, can you use it from another publication and just pull in data?
You can, and then you have to go and add your own statistical analysis for that.
Yes.
Yeah.
Okay. All right. So there's a question, how does the protocol of a prospective study differ from the protocol of an RCT study?
Randomized controlled trial was the
It's
prospective
the methodology. Yeah.
Yeah. So randomized trials are different from just normal trials. So you have 2 arms or more than 2 arms. So it already have a randomization technique. So like a random number generator. So it picks it's completely independent of the patient or the PI or the group of researchers who are performing it. It will be completely independent. So that's the main thing that's different. Randomized controlled trial versus the prospective trial. You know, prospective trial doesn't have to have multiple arms. It can be a single arm trial.
Right. Thank you. Any more questions, or is there a question that was posted before and we didn't answer? Okay, so I would say thank you so much. Thank you, Dr. Krishnan.
Yeah.
And we hope to see you in Jordan. Hopefully, we can think of collaborative projects, and all of your impressive work with the radiation and the immunosuppression is very, very impressive. So thank you. Thank you so much.
It's a pleasure to talk, and thank you for the opportunity.
Thank you so much. And thank you for our audience. We see you again tomorrow for the last day of this research workshop. And looking forward to that. Thank you so much, Dr. Krishnan. God bless.
Thank you. Have a great rest of the day.
Thank you, Victoria, for all your help. Thank you, Dr. Will.